So first, I would like to say good evening and welcome to all of you that are joining us. I know a few of you are still logging on, and some people may be joining over the course of the night. This is a 3-hour event tonight. But I just wanted to welcome you. This is being hosted by the Thoracic Surgery Medical Student Association, or TSMA. This is our inaugural CT Surgery Interest Day. This is something we're hoping to host once a year to kind of welcome new medical students into the CT surgery community if they're thinking of exploring cardiothoracic surgery as a potential career. So tonight we are incredibly honored to be hosting such a distinguished panel of guests to give medical students across the country a chance to explore cardiothoracic surgery as a career. Before we begin, we wanted to first thank our advisors for their support of our endeavors to host this event, which includes some of our featured speakers tonight, including Dr. Tong and Dr. Sultan, who will be kicking off our night. And additionally, we wanted to thank the American Heart Association's Council on Cardiovascular Surgery and Anesthesia for giving us the opportunity to collaborate with them for the second hour of this event. Now, before we begin, I wanted to share a few announcements. At the end of this event, we will be sending an email out to all of the participants, and within that email, there will be a link to join TSMA's email listserv. This will keep you up to date on all of our events, and if we're hosting anything in the future, as well as we will be able to share our newsletter with you. And we also will be sending we will be sharing a QR code at the end of the event with a post survey for all of you to take so that we can improve upon this event for next year's participants. The link to the survey will also be posted in the chat box. And just as a note, we are with TSMA looking to expand leadership positions in the coming months. So we would really, really love to have more medical students get involved with us so we can expand and grow and just further incorporate medical students into the CT surgery community. So with that, I would like to start our event. So today we are going to start off with 2 talks. They will be hosted by Dr. Betty Tong and Dr. Ibrahim Sultan. They will be each talking about general thoracic surgery and adult cardiac surgery and why you should do cardiothoracic surgery as your career. So first off, we have Dr. Betty Tong. She is a general thoracic surgeon at Duke University. And with that, I will give the floor to Dr. Tong.
Thank you, Eleanor. I am delighted to be here. And I think I'm sharing my screen. Is that correct? Awesome. Okay, well, I am, as I said, not only delighted, but very honored to be here on this first CT Surgery Interest Day event. As Eleanor said, I'm a general thoracic surgeon at Duke, and my aim tonight is to give you a little bit of an introduction into what I do, and probably more importantly, why I do it. As with any talk, here are my disclosures, none of which are relevant to the talk tonight. My journey to general thoracic surgery has been a little bit of a circuitous one. I started out in college as a mechanical engineering major, and I thought I was going to be an engineer. I worked at Kimberly-Clark as an engineering co-op, so that's a 1 quarter on, 1 quarter in school, 1 quarter working program, and as a result, it took me 5 years to finish my degree. During that 5 years, I watched a whole lot of football and a whole lot of basketball, and like probably many of you had a lot of fun in college as well. Toward the end of college, as I began thinking about what I wanted to do next, I really thought that engineering was going to be in my future. So I applied to and began a PhD program in mechanical engineering, bioengineering. At that time, there were no true bioengineering majors at Georgia Tech, so I went into bioengineering through the School of Mechanical Engineering. This is Bob Nerum, who is my graduate advisor, and as I started into my graduate program, I really began to realize that it wasn't so much the engineering part, but it was really the application of the engineering principles to biologic and medical problems. And so I at that point began to entertain the idea of going to medical school. Since I was in Atlanta, I began the somewhat obligatory volunteer experience and volunteered in the recovery room at Scottish Rite Children's Hospital. And there, I thought the pediatric anesthesiologists were they were gods. They were really great at what they did. They were nice people, and it was a terrific experience. So from there, I was lucky enough to come to Duke for medical school. And the program here at Duke is such that the basic science experience is compressed into 1 year. The first year of clinical rotations is during the second year, and then the third year is for scholarly research. So I landed in the lab of Andrew Burchuk, who is a GYN oncologist, and got interested in cancer genetics. Prior to that, during my second year clinical rotation, it just happened to be that we were all required to rotate on cardiothoracic surgery at that point, and I happened to serendipitously rotate on the general thoracic service. I thought it was great, but I thought, I have no future in thoracic surgery. I do not want to do that, mainly for the lifestyle reasons. So I did my lab work in Dr. Burchuk's lab, cancer genetics, GYN oncology, and then sort of on a whim during my fourth year in one of my sub-I, I said, okay, well, I'm going to do a general thoracic sub-I just to get it out of my system, and then I'll be done with it. So I did that, and I ultimately matched into ENT or otolaryngology residency, thinking that it was a reasonable second best and the right compromise for what I was thinking about in terms of training and my clinical experience and what I wanted to do ultimately when my training was done. So I matched at Hopkins and worked with Joe Califano here, shown on the left, who's a brilliant cancer researcher. But during my research time there, again, sort of couldn't really shake the idea of general thoracic surgery. Ultimately, I ended up switching residency programs, somewhat uncommon, and finished my training in general surgery at Hopkins, and really was mentored by Steve Yang, who you see here on the right, who many of you may know. He's a big proponent of and mentor to students interested in cardiothoracic surgery. So following my training there, I came back to Duke to do my thoracic residency, really with the aim of working with both Tommy D'Amico and David Harpole, who are now my senior partners. So when I was training at Hopkins, this is Mark Duncan, who was a general surgeon. Invariably, at the scrub sink, when we had a student rotating on service, he would ask, so why are we here? And the student would say something like, well, Mrs. Jones has symptomatic cholelithiasis, and we're here to take out a gallbladder. Or this person has an early stage colorectal tumor, so that's why we're going to do the hemicolectomy. And he would always stop them and he would say, no, we're here because it's fun. And my corollary to that is that we're here, and I do what I do because it's not only fun, but it's very challenging and it's interesting. And for me, it's very personally and professionally rewarding. So general thoracic surgery, when you think about the thorax or the chest, you have all kinds of things. You have lungs, you have the esophagus, you have ribs and the diaphragm. And often we think of general thoracic surgery as non-cardiac surgery. So everything but the heart. Many of our patients have some type of cancer or malignancy. The main types of malignancy that we treat in general thoracic surgery are lung cancer and esophageal cancer. But in my practice, I treat patients with soft tissue sarcoma, with breast cancer, pancreas cancer, colon cancer, lymphoma, you name it. If there is a cancer that can spread somewhere else, I've likely seen it. So much of what I do is surgery with a minimally invasive approach. You see our standard approach here that we use at Duke. We use 2 ports, 1 incision for a fiber optic scope and about a 2-inch incision anteriorly in the chest for instrumentation. And with that, we get to do really amazing operations like lobectomy. In this picture, you see a thoracoscopic view. This is a right lower lobectomy. We've taken the inferior pulmonary vein, we've divided the bronchus, and the structure that you see just to the right of the picture is the interlobar pulmonary artery. So we've dissected around this pulmonary artery, and we're getting ready to staple it and divide it and complete our lobectomy. We also see patients with benign diseases. So there's benign chest wall conditions, things like thoracic outlet syndrome or benign tumors of the chest. We see patients with benign esophageal disease, so things like reflux or achalasia, periesophageal hernias. And while I don't personally do lung transplantation, 2 of my 4 partners do, and that is an integral and significant part of their practice. So, when I was putting this together and thinking about why do I do this? Why do I love what I do? One, it's the variety of cases. I can fill my OR day with big cases like a lobectomy or an extrapleural pneumonectomy or something that'll take me 4 or 5 or more hours to do. It's very technically challenging. You've got major blood vessels, you've got other important structures in the chest, and it's when you're operating the chest, it's alive, and there is no doubt that this is a person and with a beating heart and lungs that are working. Part of the variety is that I get to see patients with both benign and malignant diseases, and I'm very lucky that I get to work with several different teams within the hospital. So in any given month, I will have a joint case with plastic surgery, who I work with primarily in terms of chest wall resection and reconstruction. Neurosurgery, this is a case that one of the neurosurgeons at the VA emailed me today. This is a 30-year-old man who noticed some asymmetry in the area behind his neck. And so this is a tumor that we're going to do a joint case and figure out how to get out together. I work with orthopedics, bariatrics, especially on the benign esophageal side, and obviously all of the oncologic specialties and subspecialties, and pulmonary and GI, of course, are partners in treating thoracic diseases. One of the things that I really enjoy is the fact that I get to, as a surgeon, engage in longitudinal care. And as surgeons, we really play an integral part, or we have an integral role in the events in patients' lives. And that's really something that never ceases to sort of amaze me, that this is having surgery is a major event in many people's lives, and I'm lucky enough to get to be a part of it. In terms of the variety of cases, I pulled the case mix from our service from the last week. This is not just me, this is me and my 4 partners. But as I mentioned, we do VATS lobectomies, 2 or 3 hour case, EGD DIL, or upper endoscopy dilatation, half-hour case. Segmentectomy, anatomic resection, typically for lung cancer. Esophagectomy, typically done, the MIE, typically done for esophageal cancer. Robotic surgery. My 2 partners who do robotic surgery use it a lot for the benign esophageal disease. The robot is very well suited for that. Lung volume reduction surgery, again, a benign condition, end-stage emphysema. We get to help people breathe better and sometimes get off their oxygen. Again, 4 lung transplants done this week, somewhat remarkably. And again, one of my partners did fixation of rib fractures, traumatic rib fractures. So you see that there's really a lot of different things that we get to do. And that variety, in my opinion, makes for an interesting practice. So I'll spend a minute talking about our patient population. Most of them, as I mentioned, are cancer patients. There are many days where I feel like one of the people in this picture, where I feel like a superhero at the end of the day. Again, we are so blessed and lucky to be able to be part of this episode in patients' lives, which is, being told that they have cancer is a profound event in their lives. And to be able to, with what we do and the knowledge and the skill that we have, be able to help them, be rid of their cancer, sometimes completely curative, or B, have a significant part in that treatment and curative process is really rewarding. I particularly enjoy the continuity of care. I will say that I probably would have been a lousy primary care physician or internist, because the problems seen by those practitioners are not as interesting to me. But one of the things that really struck me when I was training is that David Harpole, who's, as I mentioned, now one of my senior partners, at the end of a clinic day in pre-COVID era, his white coat would be different shades of brown, because he would walk into a clinic room and all the little old ladies who he had operated on and came back to clinic year after year after year, their makeup had rubbed off on his white coat. And I love getting my Harpole hug. I absolutely love that. I don't get that now, obviously, but I at least get my Harpole elbow bump. We get to treat patients both in the outpatient setting as well as the inpatient setting, so there's some variety there. We see folks in the clinic, we operate on them, they stay in the hospital, and then they come back to the clinic once they're better, and we get to be part of all of that. Some of our patients, but not all of them, require critical care skills, so intensive care stays. Again, not everybody, but sometimes. And again, sometimes it can be, we have days, I will admit, where the cancer wins, where we see cancer recurrence. Those are the days where I am grateful for the opportunity to be able to treat benign conditions as well. And that way you still get a win. This is a typical week for me. My kids are both partly in school now, but even when they weren't, even when they were not, when they were completely in person, I would be able to drop them off at school, typically on Mondays, and then spend Monday in the clinic. Tuesday is my block time in the operating room, so I have 2 rooms for cases all day. Wednesday is our academic day, so we have grand rounds, and at least once, if not twice a month, I'm over at the VA doing general thoracic cases there. And then we have our multi-D thoracic oncology conference on Wednesday afternoons. Thursday has now become my Zoom morning between section meetings and our various other multi-D conferences, sarcoma multi-D, VA thoracic. I spend most of my day at my desk or in my chair. And the rest of that time is academic time. I am the clinical director of our lung cancer screening program. So on Thursday afternoons, we have our multi-D conference there. And then Fridays is somewhat variable. If I have a case to put on, I'll operate on Fridays. And if not, that is academic time. I put the picture of my husband and our kids, our family, in the bottom left to remind me that it's not all in the hospital. The training is lengthy, and sometimes time out of the hospital is challenging to find. But for the most part, we live a pretty good life. My husband is actually a surgeon as well, and so we balance 2 different call schedules and clinic and OR. And when I'm in the clinic, he's in the OR, and vice versa. So somebody is out if there's an emergency with the children, as there has been in the past. But we also get time away, and we enjoy and value that time away as well, and that is important for mental well-being, mental and physical well-being. So when I came through, the only pathway that was recognized for cardiothoracic surgery was now what we now call the traditional pathway. And as we have evolved in terms of thoracic education, there are 3 pathways for training that are now recognized. So in addition to the traditional pathway, the joint training program, and the integrated 6-year pathway. So the traditional pathway, which is how I came through matches students straight out of medical school into general surgery. It's also recognized that vascular surgery residents can apply for the traditional pathway. Typically, there's some research that is involved during that 5 years of general surgery residency, and then 2 to 3 years of thoracic residency training. The advantages of that is that trainees are fully trained in general surgery, and if you many folks who choose this pathway talk about wanting to be a very well-rounded surgeon with a wide breadth of experience. I think this is really good for people who maybe think they want to do thoracic surgery, but maybe not 100% ready to jump in. The disadvantages of this pathway are that it is a full general surgery residency, and if you're not interested in breast cancer or melanoma or hepatobiliary surgery, you're going to spend a lot of time doing those cases and learning about those disease processes when you may not be completely interested in them. The joint training pathway is one where people match into general surgery residency, again, plus minus research time depending on the program, and then within that same institution, match into the joint training program where it's a combination, so essentially a 4-3 program. This still involves complete general surgery training, so you are eligible for certification with both the American Board of Surgery, so for general surgery, as well as the American Board of Thoracic Surgery. And my personal opinion is that this is an excellent foundation for people who are interested in general thoracic surgery, where we are operating on the esophagus and the foregut, and it provides a great foundation for those folks. It is extremely demanding. Our residents will sometimes flip back and forth from month to month between general surgery and thoracic, and being excellent at all of it is really hard. And the other potential disadvantage is that not all training programs have a joint training pathway. And finally, the integrated 6-year pathway is the newest of the training paradigms recognized by the TSDA and ABTS. This pathway matches folks straight out of medical school into what we call the I-6 residency. So it's 6 clinical years. Our program here at Duke bakes in 1 to 2 years of research as well, because we want to train academic cardiothoracic surgeons. It tends to be a little bit more streamlined in a focused pathway toward certification. Our program here allows these trainees to have exposure and experience on cardiac anesthesia, where they get exposure and experience doing transesophageal echocardiography. They do a cath lab rotation, so it's really, really good for people who are all in on cardiac surgery. I think most of the programs nationwide are tailored toward people interested in being cardiac surgeons. If you want to be both a board-certified general surgeon and a board-certified thoracic surgeon, this is not the pathway for you. This will only lead to ABTS certification. And there are only about 35 I-6 programs in the country, and not all of them are, as I said, as I think, created equal or successful in their training of cardiothoracic residents. So with that, I think that we should all recognize that it's not a one-size-fits-all sort of paradigm. I think for each individual person and what they want, that person should think about the training pathway that works best for you. When I think about my own training, it's more akin to what we see Billy doing here on his way to the mailbox. I certainly have not had a very direct pathway to what I do, but somewhere along the way, I recognized that it's not really the destination, it is the journey in getting there. So with acknowledgments to Shanna Blackman, who always ends her talks with a pearls of wisdom slide. One, I think it's really important that you follow your passion. Figure out what it is that's going to get you to wake up in the middle of the night and go into the hospital and take care of a patient. What is going to get you to say, I can't do that that thing or that event with my family or with my friends, I've got this case to do. Also recognize that where you are in 20 years is, it may be completely different from where you thought you would be today. What we do in medicine and surgery is lifelong learning, and it's important to recognize that and to be humble that you don't know everything, and that the day that you finish your training, you're not going to know every single thing about cardiothoracic surgery. I made the mistake of too early on focusing on what am I going to do when I get done? When am I going to be done? How old am I going to be when I get done? And that was wrong. So don't focus only on your destination. Focus on your journey and how you're going to get there. I think it's important, and I have been very fortunate to be surrounded by excellence. I fell into good mentors when I was a student, and mentorship is a one-way street. That's a completely different, or excuse me, mentorship is not a one-way street. It's a two-way street. That's a completely different talk, but choose your mentors wisely and very carefully. And finally, one of my mentors was asked for advice about obtaining training in cardiothoracic surgery, and it was a request that came by email. I happened to be CC'd on it, and this was what he said. He said, work hard, and then when you think you're working hard, work harder. So with that, I am grateful for your time. I will close with this thought that if you choose a job you love, you'll never have to work a day in your life. And I am lucky and fortunate to have found something that I do love, and hope that I've conveyed some of that to you all tonight. I'm grateful for your time and I will stop sharing so we can have questions.
Thank you so much, Dr. Tong. So all of those who are watching right now, if you have any questions for Dr. Tong, feel free to ask them in the chat, or I believe you should be able to raise your hand and we will be able to request to unmute you, and you can ask them that way as well. All right, if there are no questions for right now, feel free to think on that a little bit longer. We do have another talk and we can have time for some questions at the end. First, I would like to say thank you, Dr. Tong. As someone that is currently on a general thoracic service right now, I can completely attest that everything you say is true. It is both challenging but incredibly rewarding. So thank you for sharing your thoughts. And with that, we will switch over to Dr. Ibrahim Sultan. He is an adult cardiac surgeon at the University of Pittsburgh. And with that, you have the floor, Dr. Sultan.
Hi, thank you. Thank you for having me. And again, it's an honor and privilege to be able to speak to everyone. And I'm excited about the TSMA. I think it's a fantastic idea. So kudos to all of you guys to be able to, first of all, launch this. Second of all, get everyone excited about it. Because it's easy once you're successful, everyone will jump on the bandwagon. But to get there is not easy. So congratulations. And I'll put a plug in to the rest of the folks listening in, is really to join some of the listservs and get to know the TSMA. So a little bit about myself. I don't have slides prepared, but I'll talk for a little bit, and I'll just share you kind of my schedule. I put together a slide while watching Dr. Tong's lecture, so hopefully that helps. So a little bit about myself. I was born in India. That's where I went to. That's where I was raised. I spent the majority of my early years there. My dad was a travel agent, so my parents moved to Saudi Arabia afterwards during the oil boom in the late 80s, and I went to high school in Saudi Arabia, and then I eventually moved to the U.S. really to finish college and start medical school. So I didn't finish college because I got into medical school since I had a bunch of my credits. So as my friends and my wife constantly make fun of, I still don't have a college degree. So I got into medical school. I went to school at Cornell. And then at that point, I was really influenced. And again, it all comes back to who your mentors are and who you surround yourself by. I was, quite impressed by my mentors who were surgical oncologists and general surgeons. So I knew I wanted to be a cancer surgeon. Specifically, I wanted to be a pancreas surgeon. And so, everyone told me, like, you got to go to Hopkins if you want to be a pancreas surgeon. So I went to Hopkins to be a general surgeon and specifically a pancreas surgeon there. And that's kind of what I was focused on all along. And I never really experienced or saw heart surgery as a medical student. And so that's something I feel very passionate about now when I interact with our Pitt medical students and I kind of explain to them, how heart surgery works. And so when I was a second year resident at Hopkins, you spend approximately 6 to 8 months of your time, and maybe different now, but in the ICU rotating every third night. And so on my post-call days, and this was kosher back then, I scrubbed into cardiac surgical cases. And so I scrubbed a lot with Dr. Duke Cameron, who was there at that time, not MGH, and I was fascinated. And I was like, boy, number one, the first thing that was fascinating was like, oh boy, there's a lot of suckers in this chest. What is going on? So it was mostly confusion at first, and then fascination by how everything moved. And to me, everything moved so smoothly. It was kind of like being watching an orchestra. And I thought maybe it's just him because he's such a good surgeon. Then I watched other heart surgeons and it was all like that. And I was like, you know what? I have to do this. And I completely turned around 180 degrees and I said, this is what I want to do. And so I finished my general surgery residency. Again, I went through the traditional pathway, as Dr. Tong alluded to. I went to University of Pennsylvania to do my standard cardiothoracic surgery fellowship. And then it spent an extra year dedicated to subspecializing in aortic surgery and learning about transcatheter technology, because that was a big boom back then. And I almost decided to stay there, but fortunately I heard about a job in Pittsburgh. Never been to Pittsburgh before. I thought, I didn't really like the Steelers, didn't care much for the weather, but I visited and I fell in love with the place, the hospital, the system. So I took the job here, and this is my 5th year now, and I've been very, very fortunate to have this job and I've enjoyed every minute of it. So I'm an adult cardiac surgeon, as Eleanor alluded to, and an associate professor of cardiothoracic surgery here. And I'm a director of our aortic center at UPMC and director of the transcatheter valve center here. So why I chose cardiac surgery? Honestly, because I was fascinated by it and I thought it was very cool. That's the simple, honest answer. Why I really chose cardiac surgery internally, I thought that was of all the technical operations that I watched, I thought that was the most technically challenging specialty that I saw with respect to sewing and constructive. And I kind of divide surgery into 2 kind of subspecialties broadly. There's kind of constructive surgery, which is, cardiac surgery, vascular, plastics, transplant. And there's what I call destructive surgery, which is surgical oncology. I won't say anything about thoracic, but there's destructive, cancer surgery along those lines. And I always kind of gravitated towards the constructive part. So that was a relatively easy decision for me. And I knew it was hard, and I knew it was going to take a lot of hard work, and it was hard. And training was extremely hard, but it was rewarding, and it is rewarding. And honestly, I tell all our medical students here that I truly feel that I have the best job in the world. And I wouldn't tell my boss this, but I would do this job for a lot less pay because I sincerely love doing it. And truly, as Dr. Tong alluded to, it truly is a privilege, right? It is, we're honored and it is a privilege for us to be part of patient's life. And I think when somebody has heart disease or is having some sort of heart problem, that's really a very personal thing for them. And for us to be able to take care of it makes a big difference. And to me, the fact that somebody comes to you with some sort of heart disease, whether it's aortic disease or valve disease or coronary disease, and the expectation is, you talk to them in the office, you put them to sleep, you open their chest, put them on the heart-lung machine, stop their heart, fix their heart, restart their heart, close their chest, and expect that they would be home in about 5-6 days and move on to their life, I think is very cool. And I think if you can do that, I don't think there's anything else in the world that beats that feeling. And then, and truly the best part of it is not, you know, as much as I love operating, the best part of it is when we see our patients back in the office who feel dramatically better. We're truly grateful to you for having, you know, saved their life in certain circumstances. For instance, when they present with a dissection, or in certain circumstances, make them feel better if they have bad coronary disease or bad valve disease. So I think those are kind of the, you know, the big things that I think about. You know, the fun thing about heart surgery is that there's no small case. Every case is a big case. You know, doesn't matter if you're doing a coronary. I mean, today, you know, I did 2 cases today. I did a total arch replacement and a redo root for a prior operation and a new aneurysm that formed, and I did an aortic valve replacement after that. And so one of them was a very challenging case. One of them was a very relatively easy case, but I still don't consider either of them small cases, because there is no such thing as a small case in heart surgery, because I think anything can go wrong at any minute, and you kind of have to be alert mentally and physically to be able to handle that. And I think that's quite important. And so the worst thing about heart surgery is there are no small cases. So I'd love to, you know, I'd love to say, you know what, man, I just need a break today, and maybe I'll just do some you know, carotids or something along those lines. And you just don't have that in cardiac surgery. And so I think that's something that's important to remember. I think with respect to diversity of cases, I think there's a healthy diversity of cases that we see in cardiac surgery, you know, but at the same time, it's all a combination of one or the other. There's really kind of 4 or 5 major categories of cases, and everything else is about that. And most people who kind of are, as my wife says, there's really 3 operations you do. And I say, yeah, that's true. But the beauty of it from my perspective is, you know, I want to do a better job every single day. Or I want to be able to, now I want to, you know, in my situation, I want to be able to teach our residents to be able to do a better job at that particular operation every single day. And I think that's what I find challenging and exciting about what we do. So I can share my screen here. Let's see. So I don't really have any disclosure. And as I said, I just made, apart from the fact that I love my job. So this is kind of how my schedule looks like on paper. And so, you know, Monday, typically we start off at 6:30 in the morning with a multidisciplinary heart valve meeting. We talk to multiple subspecialties, for instance, cardiologists, you know, that are echocardiographers, interventional cardiologists, and non-invasive cardiologists, a combination of so. And we talk about patients with heart valve disease, which approach you take, whether we take a transcatheter approach or open surgery approach. And then I go on to my day, and I typically do between 2 and 3 open cases on Mondays, and that depends on whether or not I have a half day of afternoon clinic. Tuesday is you know, I serve as one of the associate program directors for our residents, thoracic surgery residency. So we have a educational leadership meeting every Tuesday, and we go over residency issues or resident issues, et cetera, et cetera. And so that's what we do. And then I do my lab or research meeting after that. And then most of the rest of the day is clinic, followed by some budgetary finance meetings that we run for our Heart and Vascular Institute that I participate in and we talk about. So Wednesday is typically our education day. So about 3 hours, everything stops, and you know, we talk about M&Ms. There's grand rounds. There's a case conference, so we speak about difficult cases, challenging cases. You know, how to do something differently, et cetera. And I typically do 2 open cases that day. And then we have, again, another conference in the afternoon that we routinely go to, which is CANF conference, where we, again, work with our interventional cardiologist colleagues, and we look at different heart caths, which way to go. Thursday is typically my endovascular day, but sometimes this turns into an open day depending on my schedule. And I do 4 to 5 either TAVRs or TVARs this day. And that's and this is just, and this alternates depending on what the scheduling needs are. And then I do some hospital administrative meetings in the afternoon. And then Friday, typically Monday and Friday are typically my 3 case days. So that's when I do about 3 open cases. And then I spend some time with medical students because I help advise them at Pitt. And so I go whether right now it's interview seasons, for example, so doing mock interviews, things like that is kind of important and big. So we talk about that. A few months ago, that was who to get your letters from. A few months ago was, well, how do you make your application look good, et cetera, et cetera. So this is what it looks like on paper. But then as of this afternoon, between Saturday and today, we had, I kid you not, 5 type A aortic dissections that we did. So everything here basically gets disrupted. And I was told by our ICU charge nurse today that I'm not allowed to do any more cases because our ICU is full. So it's, so it completely can be disrupted at a moment's notice. But I'm lucky to have great partners who work well together, who take some of the load off, et cetera, and vice versa. But again, these things are kind of how it looks on paper. But again, the thing about heart surgery is it's very unpredictable and things can kind of change any minute. So that's what I would say with respect to that. And I'll show some of you, most of you may have already seen this, but I can share a video of what this looks like typically. So let's see. So this is a video that I think you can see that, right? This is a video of a patient with a type aortic dissection that Edgar had edited for us recently. So the typical presentation again is some middle-aged man with hypertension that comes in, and you see a CT scan that you get in the emergency room that shows a bad aortic dissection. And this is relatively simple from our perspective. And this can be done in different ways. So this is us opening the pericardium, identifying the aorta, and then putting 2, again, I'm going to talk basically, I know there's high school students on here too. So you put 2 tubes or cannulas in the heart, one in an artery, which is the ascending aorta, the biggest artery of the body, and one in the atrium, which is the biggest vein of the body. Once we do that, we put the patient on the heart-lung machine and then cool the temperature down so as to stop circulation to the brain and to be able to do surgery in this situation. So this is kind of what the circuit looks like when you're draining the heart and recirculating blood flow this way. Once you do that, you can then stop the heart by giving a potassium-rich solution. You do that next because you want to, again, resect and remove all this kind of grungy aortic tissue. And you're doing that here. And you try to take all this stuff out. And again, the heart stopped now, and we're trying to protect the heart while operating on it. And again, efficiency and expeditiousness is important because you can't keep the heart stopped for too long. Then we take this piece of woven fabric and basically sew it and recreate the aorta, creating a neo-aorta. And again, you have to be very, as I said, while being expeditious, you have to be careful about this really being good anastomoses and doing it carefully, because as you can imagine, this is where the body sees the highest blood pressure, so to speak, in the entire body. And so you want everything to be nice and watertight or blood tight, so to speak. This is the other end of that tube, so to speak. So I mean, a lot of heart surgery, as you'll see, is really about plumbing. So it has a lot to do with how to. It really has a lot to do with how you want to fix that plumbing problem. So if you're dealing with coronary artery disease, you do bypass surgery. If you're dealing with valve disease, either a leaky valve or a tight valve, you open that up and fix the plumbing. And if you're dealing with an aneurysm or a dissection, you're really, again, rerouting the blood supply to the brain and the rest of the body. Here we're showing these smaller grafts to the left carotid artery and the right and the innominate artery, which supplies the right side of the brain. Then we take out all this kind of dissected tissue, again, allowing for a nice, good plane to be able to do this safely. This is how we measure what size graft to put in. And again, we want to do this carefully to ensure that there's really no issues. And then we hook, again, the brain back up. Sometimes we have to kind of go into the neck and fix people's carotid arteries when they clot off with a dissection. This is what that looks like. And then you make a little tunnel from the chest to the neck, and then reperfuse the brain that way in these patients who present with stroke and an aortic dissection. So similar concept when we're doing these cases. I think the rest of it is essentially a variation of surgery. As I said, there's really 2 to 3 different surgeries, and we just try to make different variations of it to keep ourselves busy, so to speak. But anyway, that's kind of an overall day or schedule things look like. I think, as I said, one of the things that makes this very exciting for us is really the gratification, so to speak, or the ability to feel how much of a difference you've made in patients' lives. And that's really what keeps us going. And it's important to remember, as life expectancy increases with time, people are going to need more and more cardiothoracic surgeons, whether it's cancer surgery or heart surgery. That's going to continue to be the case. And I think it's a phenomenal time to be a CT surgeon. I think, we always talk about, everyone asks about, well, what's going to happen to CT surgery? All these, transcatheter endovascular things are happening. What's going to happen to cardiac surgery? And, I always say, the reason thoracic surgery was created was for tuberculosis. That was the primary reason back then. And none of us do that anymore. It would be shocking for you to find a thoracic surgeon who operates on tuberculosis. So something to think about. I'll stop there so that way everyone has a few minutes to ask some questions for Dr. Tong and myself. Thank you again.
Thank you so much, Dr. Sultan. That was great. All right, we do have some questions that have been posted in the chat. They are for both Dr. Sultan and Dr. Tong, so feel free to both answer them. So the first one I'd like to start off with was asked by Mary Siki. My apologies if I'm incorrectly pronouncing your name. She asked, you mentioned that you recommend gaining exposure to cardiac surgery early on in your medical training. What advice do you have for medical students who want to gain more exposure but don't necessarily have a dedicated program at their institution? She would like to hear from both Dr. Tong and Dr. Sultan.
I guess I'll start. Hi, Mary. It's good to see you again. I think there are several potential ways to get exposure. One is through some of the formal programs, through STS, AATS, and the Southern. There are the Looking to the Future program for the STS meeting. There's the AATS Member for a Day. The STS sponsors the Brooks Scholarship. I'm sorry, STSA, so Southern Thoracic, sponsors the Brooks Scholarship. For women, there are opportunities through the Women in Thoracic Surgery organization as well, so scholarship opportunities or the Scanlon Award as well, which is geared specifically toward women students and trainees who do not have women cardiothoracic surgeons at their institution. I think so those are sort of the formal pathways to get exposure. I think there are informal ways to do that. Certainly, I think any of the advisors and faculty members in this organization would be open to at least having a conversation or establishing some relationships despite the distance. Also, one potential avenue to pursue would be to contact cardiothoracic surgeons in your community. There are plenty of folks in community practice who I would like to think would be open to having somebody talk with them and potentially shadow them through their daily lives.
Thank you, Dr. Tong. Dr. Sultan, do you have anything to add?
Eleanor, he said he stepped away for 2 seconds to answer a phone call, so maybe we can move on to the next questions.
Thank you. So the next question, there are lots of questions. My apologies if we can't get to all of them. We will be wrapping up in about 5 minutes. Let's see. Okay, Dr. Tong, this one is for you. Someone wanted to ask, along your path to general thoracic surgery, did you have different mentors during your different phases? Maybe if you could talk a little bit more about the mentorship that you mentioned in your talk as well.
Absolutely. When I was doing research, I had research mentors. Along the way, I have had some mentors sort of throughout my journey. Again, one of those is my boss and now senior partner, Tommy D'Amico. But just like relationships with friends and even maybe family sort of change and morph over time, relationships with mentors can do that too. So I think again, it's important to be intentional about mentorship. It should not be something that's convenient, and it should be mutually rewarding and beneficial for both. So yes, the short answer to the question is yes. During different times in my training and journey, I have had different mentors, and I have mentors now. I have people who are guiding me through, or who have helped to guide me through the promotion and tenure process. And it doesn't stop, and you pay it forward. So I have been the beneficiary of outstanding mentorship, and I try, I'm not always successful, but I try to pay it forward to the residents and the students that I work with as well.
Great, thank you so much. And I think we have time for one more question. I thought this was a really interesting question asked by Speed Rogers. So they were wondering about a role of humanistic medicine in thoracic surgery and addressing cross-cultural surgical care in an increasingly globalized world, which with the variety of cases that you're talking about, I'm sure this is something you experienced. So would love your input on that.
I think that's a really interesting question. I think that certainly the world is shrinking, number one. I was fortunate enough to be on the teaching faculty for a course that was originally supposed to be in person in Columbia, the country, not the university, that was then broadcast rather than an in-person meeting. Obviously, we did an online platform, and there were 230 surgeons, thoracic surgeons from Latin America tuning in. So the world is becoming smaller and smaller. I think we have to recognize that not all places are resourced the same as we are here in the United States, and we have to be culturally aware and competent in terms of how we can provide advice on best practices. I think there's always a side for humanism in medicine, and it begins with a dialogue, I think, among all of us. And thankfully, technology is helping us with that, and helping us to cross those time zones.
Great, thank you, Dr. Tong. Dr. Sultan, do you have anything that you would like to add at the end? Also, just so everybody knows, Dr. Sultan is also a member of our next panel. So if you do have any further questions for him, he will be available to answer in the next hour as well. But if you have anything to add, Dr. Sultan, feel free.
I sorry, I had to step away to take a call from our transfer center, so I didn't hear the question. But no, again, I want to thank you for again organizing this. I think it's wonderful, and I think a lot of you guys are going to have questions as you hear more and more of us talk. And I think the important thing to realize is that when you see somebody so happy about their job and so passionate about what they do, that's always a good sign. You know, you don't want to go into a specialty or subspecialty where you have a lot of miserable folks, and that's never good. But anyway, the fact that you know we're out here kind of beating our chest about how much we love doing what we do tells you everything that we feel, how we feel about our specialty and the future of it, so to speak. And I'm happy to answer some of the remaining questions in the chat or email or whatever the best thing you think, Eleanor, to do this, so we're able to capture everyone. So.
Absolutely. If you actually, I think what would be ideal is since we are organizing this, we can collect the questions and we can email them to you after the talk, and then you can get back to us with your answer, and then we can share them with all the participants. So with that, I'd like to wrap up our first session. So first of all, thank you, Dr. Tong. Thank you, Dr. Sultan. Both really enlightening talks. It was great to get exposure to both general thoracic and the adult cardiac aspect of cardiothoracic surgery. So students can really see that breadth of variety that you get within cases, the different challenges that you get, and how that kind of affects what a week in your life would look like.
So this is Brad Leschnauer. I'm a cardiac surgeon at Emory University in Atlanta. And we designed this 1-hour webinar to really answer important questions for medical students having interest in cardiothoracic surgery, and really giving you access to a wide variety of faculty and residents. And we thought that this would be a valuable interactive session for you. We, thanks to Dr. Han and Dr. Sultan, who were instrumental in setting this up, and they passed along a variety of questions that I've sort of compiled to make up the first 5 or 6 questions. And we have basic scientists, surgeons on the panel. We have integrated residents. We have people who have gone and done a general surgery residency for the independent pathway. So we feel that we've got all bases covered. So when I am going to moderate this and call on the faculty, I'm also going to monitor the chat questions, and we can try and see how many we can get to. But let's get started. So the first question is a very important one that's always asked. What is the best training pathway? Should I do an I-6 or should I do a traditional independent pathway? So I think to start, I want to hear from the residents who are going through it and why they chose their various pathways. So let's start with Dr. Pedroza from Stanford. If you can sort of tell us a little bit about where you are, your pathway, and why you decided on going an I-6 path.
Sure. Thanks, Dr. Leschnauer, and thanks to TSMA for including us in this. I'm a third year, well, I'm a 4th year resident at Stanford now. Our program is split, so we do 6 years of integrated and 2 years of mandatory research. So I'm in the middle of that research time now. I was also a medical student at Stanford, so I had great exposure to our I-6 program here. And at the time, we didn't have a traditional CT track, but we've since reactivated that in the last few years. But I think in my case, I had great exposure to a successful I-6 program, and I met a lot of residents who were very happy with their training and went on to get good jobs. And so for me, that was a really good sign to me that that was going to be a very functional program. The other thing was that I was pretty sure early on that I wanted to do cardiac surgery. I think Dr. Tong mentioned this earlier in the session before, and I think it's a great point that these programs are largely very focused on cardiac surgery. And so knowing that I was more interested in doing cardiac than thoracic, that made it sort of an easier choice for me.
Dr. Han, let's hear your take on it.
Yeah, hi everybody. My name is Jason Han. I'm a 4th year resident in the integrated program at Penn. It's a very balanced perspective for me, especially in the presence of some of the really, really great general surgery residents who have done traditional pathways at Penn and that I've known. Yves was a super fellow when I was a sub-I at Penn. And in that way, I've always seen some of the most mature and accomplished general surgery residents come through and pick up CT surgical training and get so much out of it during that time period. The reason I ultimately ended up going into an I-6 program, well, I think first of all, if you're very enthusiastic about doing CT surgery training up front, it's hard to think about delaying that gratification for 5 to 7 years. But another thing that I was thinking about is that in an integrated program, and I think the model is improving every year, you get earlier exposure to so many diverse aspects of CT surgery, surgical and non-surgical. A lot of my rotations in the first 3 to 4 years are focused on doing a lot of vascular surgery, a lot of thoracic surgery, a lot of endovascular surgery, robust TAVR and TEVAR experiences that I would hate to lose if I were to focus solely on learning open operative experiences for a very intense period of time. And I liked having that sort of gradual introduction into many different aspects of CT surgery. You get to meet and form relationships with cardiologists along the way. A lot of interventional cardiology fellows end up becoming your friends, a lot of echocardiographers, relationships that I didn't envision forming when I initially thought about entering into a surgical specialty. So when I think about choosing between pathways now, I really enjoy that it gives you a very large breadth into the area of CT surgery, because I do think that the field is becoming very interdisciplinary, and the field is changing in ways that you cannot necessarily predict. So by having a lot of exposure early on and having a lot of balanced exposure, it can give you a lot of things to think about early on to position yourself for the future.
Okay, and then for the independent pathway representative, Dr. Lawrence, who's at Cornell.
Yes. Hi, thank you so much for having me. So I am coming from the traditional side of things. So after medical school, I applied to general surgery residency. I'm now in my final year of general surgery training. So that's 5 clinical years. And then at Cornell, like a lot of other general surgery programs are moving in the direction, there's 2 mandatory years of research with that time. I chose the traditional pathway because I really didn't have a lot of exposure to CT surgery during medical school. I saw one cardiac case and I thought that it was amazing, but I spent most of my clinical clerkships on the trauma service, the emergency general surgery service. And so for those reasons, I thought I was going to be a general surgeon. During my general surgery training, I was really fortunate to get some exposure to cardiac surgery. I ended up spending some time in the lab focusing on cardiac surgery to get more exposure, and then ultimately chose that to go into. But the main reason for me to go via the traditional pathway was just that I wasn't confident that that's what I wanted to do as a medical student. I think that there's some great things about general surgery training. You get a huge breadth of experience. I've gotten exposure to open surgery, endovascular surgery, robotic surgery, laparoscopic surgery. And I think that all of these things will ultimately make me stronger. I think it takes a lot of time to sometimes get your confidence in the operating room, learn how to lead and to manage teams. And I think the advantage of coming from the traditional pathway is that you gain all those skills and then you get to go into your specialized training with all of that under your belt. When you're coming from the traditional pathway, you apply during your PGY4 year. This year in the match cycle, there were about 120 applicants, and I believe there were about 80 spots. So it's roughly about a 70% match rate coming from the traditional surgical perspective. The amount of spots available to traditional residents seems to have plateaued for the last couple of years. I know that as I was coming up in the general surgery program, there was some concern that there might not be as many spots since there are more integrated training pathways, but it does seem like there have been, there will always be spots for people coming from the traditional pathway.
Thank you, Kendall. Now let's hear a little bit of what the faculty thinks, the attending surgeons think about the 2 different pathways. Dr. Rove, I'd be interested in your opinion.
Yeah, so I did traditional and went through general surgery at University of Colorado, and then went to thoracic surgery residency at Washington University, and then now I'm back at University of Colorado in cardiac surgery. I am very similar to Kendall in that I didn't have an idea that cardiac surgery was in my cards when I applied to general surgery. So I discovered thoracic surgery pretty early on, intern year, had a great experience there. And that's basically what prompted me then to apply to thoracic surgery. And I switched to cardiac in the middle of my fellowship. So, I mean, I was like 110% thoracic when I went to WashU. It's a 2-year program. So I was drinking from a fire hose, switching to cardiac. And so I don't think I ever would have even considered I6 you know, because that just wasn't in my cards at the time. But I love it, and I love where I ended up, and I love that general surgery traditional track gave me the opportunity to do that.
Thanks, Jessica. Dr. Fishbein, tell us your perceptions and the differences, since you've probably trained in both for the and have the most experience of the people on the panel of training people that have gone through both pathways.
Yeah, thanks, Brad. You know, for full disclosure, I am a little biased just because, you know, I developed the very first integrated program in the United States. This program, you know, was, you know, we see that in Canada and similar in Europe, but, you know, first let me say that I think it's important to have all these different programs, exactly for what Dr. Lawrence and Dr. Rove said. A lot of people, you know, don't decide until later. And ultimately, for our field, we just want the very best people to go into cardiothoracic surgery. And so whether you decide very early on or later, we don't want to lock out anybody to the field. And so that's why it's important to have all the different training paradigms. The reason why we started it at Stanford was that really the general surgery training has changed since a lot of us went through it. It's no longer a lot of open surgery. Almost everything is endoscopic or endovascular. And so what we found was that when people came to operate for cardiothoracic surgery, or really cardiac surgery, they were behind technically. And additionally, our field is becoming more and more complicated. So, you know, what Dr. Hahn was saying now, you have to be able to do open surgery, but also feel comfortable with your wire-based skills, that you can do TVARs and TAVRs. And to learn all of that in a 2 to 3 year residency is very difficult. And so we felt, well, why not take people very early on, straight out of medical school, and teach them what they really need to learn, both open and wire-based skills, do it over, you know, 6 to 8 years, and really make them experts in the field. Now, the caveat is really a lot of these training programs are sort of set up to, you know, train really a cardiovascular specialist. And let's say you want to go into general thoracic, then I actually think that either you need to create a specific general thoracic I6 program, or probably what's more common is, you know, people do general surgery, and then, you know, really all that endoscopic work, you know, or mobilizing the stomach, all those things you need to do for general thoracic are so important that you get from your general surgery. So, you know, that's sort of how we decided to develop the program and sort of the benefits of both.
Yeah, and I just want to add that it's what fits your particular interests, needs at that time of your life. And from somebody, as somebody who looks at applications for both pathways, it does not bother me at all to see someone applying to both, given how competitive the I6s can be. You know, we've seen great people come out of both pathways. So if you're undecided, it seems like an independent pathway would be the way to go. If you know you want to be a cardiac surgeon and you can get into an I6 program, that is a very good pathway. We're going to, unless the audience has a specific question on this topic, we're going to move on. Okay, so the second question is, are there examples of cardiac surgeons doing both basic science research and clinical practice? And how do I6 programs support the development of training that kind of surgeon scientist? I don't think Dr. Gleason is on the call yet, but we do have Dr. Fishbein, who is a true surgeon scientist basic scientist has an NIH R01 funded grant. And this is right in his wheelhouse. So Mike, tell us about your pathway with regards to the basic science training, how you did it, and then how you incorporated that into your training program for future surgeon scientists at Stanford.
Thanks, Brett. So yeah, I do. I think really the sort of the basic science cardiothoracic surgeon, there's really not that many of them. I probably know, the people across the country, but saying that, I think really science is important, not only basic science, but also clinical outcomes research. And I would say the majority of cardiothoracic surgeons do outcomes research. And and that's so important because that's how we learn what's the best treatment options and techniques for our patients. For me, I love doing the basic science part. I'm a thoracic aortic surgeon, and my research is looking at the pathophysiology of the aneurysm formation. So for me, it's really gratifying to not only see what's happening in the operating room, but to sort of understand the problems and then try to advance the field by learning the basic science component of it. And, it almost makes me feel like a sort of the complete surgeon scientist, making the two of them complement each other. And it also gives the surgeon has something that a lot of basic scientists, pure basic scientists, don't have, and that is access to the patients and, let's say, tissue from the operating room or getting blood samples. And so we really can have a translational, benefit. So how do you actually do that? Well, in our integrated program, we've incorporated, as AJ said, mandatory research time, much like what we do or many programs do for general surgery. And so, you could either do it after the second or third year. People have to do at least 2 years, but we provide support if people want to get also advanced degrees and spend longer time, whether it's a PhD or a master's in, let's say, statistics. I think if you want to have an academic career of running a basic science lab, it is mandatory to do that research time, because even when you go on to then get your first job, you have to show that you obviously have spent time in the lab, that you're productive, so you want to be able to get publications. And then, it'll be important when you start your first job to be able to get a startup package and the support of your mentors to get your basic science lab going. And then, and other people I'm sure could also comment about, there's a number of awards that we can get from our societies to help with very early career basic science pathways, whether it's through like the AATS or different foundations.
Thanks, Mike. I can't emphasize how difficult it is to be a busy cardiac surgeon and a basic science. And Mike is incredibly humble, but there are literally, you could probably count the people on one, maybe two hands in the country. It's that difficult. That's not to discourage anyone. It should be, if that's your aspiration, it's doable. It's just that cardiac surgery is unlike a lot of fields that lend themselves to have a basic science plus surgical career. The obvious one seems to be like renal transplant, where you see a lot of surgeon scientists who do a week of rotation and they literally do one operation, a kidney transplant or a liver. And it's a fantastic model. In cardiac surgery, it's a use it or lose it profession in terms of your skills. And because it's that technically challenging of a field that you need to be doing it often to be doing it well. and so having said that, I think that most programs will allow, offer the ability, should you want to do some basic science or outcomes research, as Mike had alluded to. Those options exist in I6 and independent pathways for sure. Dr. Sultan, comment to us on the I6 and independent pathways at Pitt in terms of lab time.
Yeah, thanks, Brett. So we have, we were fortunate to have both the I6 and independent program, and I think we have fantastic residents in both pathways. Because of the nature of how the programs are designed, dedicated lab time or research time for the independent pathway residents just doesn't formally exist. I think a lot of them write some manuscripts with us during their 2 years, but it's hard to, most residents don't want to spend additional time, just, especially after having spent time during their general surgery residency and have taken time off of the lab. And so they're ready to graduate and be heart surgeons or general thoracic surgeons. The I6 program, however, it's we don't like to say mandatory, but it's highly encouraged, unless you have a PhD already, to go into the lab for 2 to 3 years, depending on what your area of interest is. And I'd say, depending on what folks want to do, I'd say about 2/3 end up getting some sort of a master's in clinical epidemiology or MPH while working on clinical outcomes, big data research. The rest, kind of 1/3 of the residents, go into one of our basic science labs. And I think depending on what you want to do with your future, I think those options exist. And I think the thing to remember is, depending on what city you live in, there's other institutions that you can work with. For example, having Carnegie Mellon here allows us to work with them on big data and machine learning and artificial intelligence, which again, Pitt has a big footprint in that, but not as big as Carnegie Mellon, which has the largest in the country, for instance. So I think, those are some of the things that I think you can take advantage of depending on what institution you're in, depending on the city.
And let's go down the pathway or down the panel in terms of what everyone did for their research time. So I did my general surgery research, or my general surgery, at Penn, and I spent 2 years doing basic cardiovascular large animal work in the Gorman lab, and it was fantastic. And then once I got back into the clinic, I transitioned to doing a lot of clinical papers, as Ibrahim just sort of alluded to. And then as an attending, I've tried my hand at both and have not been able to get funded for basic science stuff yet, but have been productive with clinical research. AJ, what is your lab focus at Stanford?
Yeah, first I have to echo, I think Dr. Fishbein is an expert at this stuff, and I have to also disclose he's my PI. But we're working on, so I'm very much on the vein of doing very basic science research, fundamentally on Marfan syndrome and other aortopathies. But we're looking at subcellular level RNA regulation, very granular stuff. So I agree that it's like a very small subset of folks that are doing this, but I also think that that's somewhat of an advantage because you're not competing against a ton of people that are trying to get the same funding mechanisms. So, we're going to think we have another question later about mechanisms for funding and things like that, but looking into like AHA funding and NIH funding rather than some of the more traditional surgical societies has been kind of our wheelhouse, at least for me and for the folks coming behind me in the lab.
Jason Hahn, what is your research at Penn?
Yeah, I just started my research time in my first of 2 years. It comes between our clinical PGY third and fourth years. I'm working with Dr. Lurie. He's a translational PI. He works mostly with heart failure, MCS, and heart transplant patients. I've had interest in that area for a very long time now. I've mostly been involved in the clinical space leading up to this time. I'm involved in some translational aspects as well. And because I've known, I think one of the nice things about developing a longitudinal relationship with the mentor is that they get to really know the nuanced aspects of your interests. So he's flexible with not only mentoring me in some of the areas that we've already been working on, but a lot of my other interests extend into ethics and mixed methods research as well. And he was very supportive in letting me know that these areas may become very influential in his day-to-day practice, and was willing to lend me support. So I think it's, in addition to picking an area of research or a topic, I think it's also important to figure out what your relationships are going to be, and also trying to figure out as an applicant to a program what the philosophy or the culture of that program is towards you becoming an academic surgeon and pursuing these types of opportunities. Because I don't think it's homogenous across the board. I think some institutions will tell you up front that that's what they value, and some institutions may tell you that this is something that you may have to pursue on your own. So from a student's perspective, I think if that's important to you, that's always a question that's worth asking.
Kendall?
So I went over to CHOP and Penn to do my 2 years of research after my PGY2 year. I worked with a fetal sheep model. We worked to develop an animal model to study congenital heart disease. So we were particularly interested in studying the effects of prenatal hypoxemia on brain development using this sheep model. I had a lot of fun doing it. I did not have a lot of basic science experience prior to doing this, so I learned a ton in the lab. I think that coming from a surgical background actually helped tremendously, because not only did it give me insight into the pathophysiology of some of the diseases, but it also put me in a unique position to help with the surgeries to create the animal model. So that was something that when I was working with other basic scientists that didn't have that background, you know, they couldn't help modify the cannulation techniques. They didn't have the critical care experience that I had to help take care of the animals. So I think that it can actually be advantageous coming from a surgical background to do some of these basic science projects sometimes.
And I think it's important for the audience to realize that if you, like Kendall did, if you what you want, it is not uncommon for residents to go to different institutions for their lab years. So keep that in.
I was at large animal model lab, and then they published a ton of UNOS papers on the side, so to speak. So that was kind of the Hopkins lab model, and I didn't do that, but the rest of my friends did. Having said that,
Yeah.
Sorry, go ahead.
No, I was just going to compliment you, and yet Eves has been extremely productive on the research aspect. So tell us how you, despite not doing dedicated research time, gained your skills, so to speak.
Yeah, I think it's one of those things. I think, everything else is kind of relatively easy once you kind of get the hang of heart surgery, right? So I think once, I knew it was important for me to distinguish myself at a much more aggressive rate, if you may, compared to the rest of my colleagues or I'd say majority of the folks, for instance, on this panel, who would spend dedicated time in the lab, published, gotten grants, etc. So for me, it was very important to be able to do that at a much more accelerated rate. And so the way I did that is a few different ways. First of all, I worked with some of my close friends who had spent that time to get some of the basics down. Second, I think it's important to work with people who are good at what they do. So for instance, our institution's very good at supporting this. We have a dedicated statisticians and database managers and relatively high level of clinical analytics that's available. So I spend time with them. I mean, I spend several hours a week learning everything from data analysis to database management, et cetera. And to me, that was very important. And I think it paid off. And now, we're very productive and we're very proud of it. On the basic science front, that was much harder for me. I just submitted an R01 this past cycle. We'll see how that gets scored, but that was much harder. I mean, it took me almost 4 years to put together data. That's not something I had background on, so I had to spend extra time really late during the day, afternoons, evenings, and weekends, learning with some of our PhD colleagues about basic lab skills and experimental skills and kind of methodology and strategy. And so it wasn't easy. Let's just say it would have been easier if I just spent those 2 years in the lab in retrospect. But I think it all kind of balances out at the end, quite frankly.
Okay, and Jessica, tell us your experience, and then we'll move to the next question. You got to unmute.
Sorry. And I apologize, I've been in and out. I'm on call and the pager's blowing up. But so I did 2 years in the lab in general surgery. It was a thoracic lab with Dr. Wyant, and I did a lot of basic science and cell culture and things like that in an animal model. And now oh, Tessa, did you have a question? Or, okay. And now as a faculty member, I'm doing some clinical research, and I do have an animal model for something that I'm doing in conjunction with bioengineering. And so all those things are kind of in development still. I'm in the first, 2 years of being at University of Colorado, and I don't think I'm as accomplished as Dr. Sultan by far, but I think his comment does ring a little true about, like, once you kind of get the clinical stuff settled down and you have your schedule and you've got things worked out and you have a flow, I have found that this year especially I've had more time to think about things, write, and be productive from that standpoint. And it does make a really big difference what kind of support you have where you go. Like if you have a very powerful, well-staffed clinical group that can help you with your research questions and the statistics, and a group to learn from, I think that's very helpful. And I think you have to be careful when you have to create some of those things yourself, because there are only so many hours in the day. But yeah, that's my experience.
Okay, let's continue on. The next question is, given, this is an important question. So given that residency training is competitive, especially I6 programs, what can the medical students do to distinguish themselves? And I will say that certainly it was an unbelievable increase in the quality of applicant when we started doing the I6 program at Emory. We suddenly got a lot more people who were, of a higher caliber that were interested in cardiothoracic surgery, probably because they didn't want to spend 10 years training like a lot of us did. As an aside, one other thing I wanted to mention about the research: do not be in a rush to finish. When we say that it's all about the training and the journey, and you heard it from Dr. Sultan, his regret in not doing it. When you're in the training, you think, I'm never going to finish. It's going to take forever. But those skills, first of all, taking 2 years out and clearing your head is invaluable. And then the second thing is, you'll never be able to replace that time again in your life. So do not be in a rush. It took me 10.5 years of training, and I don't regret it at all. Okay, so what can the medical students do to distinguish themselves? Jessica, why don't you start off with your opinion when you look at applications?
Yeah, good question. I think that, and this is med students, so this is going into surgery residency, right?
This is
I6, because
this is how do they make themselves the most attractive applicant on the paper as they go into,
And I think if it was, can I answer this as a traditional? Because I haven't interviewed any I6,
Sure.
and I didn't
Yeah, we have
personally interview for I6. Because I think it is probably a different angle if you're applying for I6, and there's, if everybody's already focused and knows they want to do cardiac, I think that's probably different. But I think from a traditional route, I do think that the scores are the first thing, obviously, everybody looks at, and you can get even weeded out based on scores. So that's critical. And then publications is really good, and authentic publications where, you've really put in the work, and that you're able to talk about those experiences and that they were meaningful for you. And that you were able to find something that you could focus and really dig your teeth into. Definitely don't do it if it's not interesting to you. And the letters also come through as really important. So the relationships, I think, that you establish, the mentors. This is kind of getting back to that research time, but when you do take time out for research and you go to the meetings and you present, there's a lot of people that you can meet at the meetings, and you win awards, you get to talk to all these people. They're your discussants for your papers. And I think that really helps too, because that helps to validate who you are and what you've done while you're in training. And I think that goes a long way. I think we all do read the personal statement. Don't blow that off. There's some really interesting stuff there, but I've just been blown away. And like Kendall was in the last group. I mean, Kendall's awesome. Kendall's amazing. So I've just been blown away by the people. It is a really competitive group, but very authentic and really motivated.
When I look at some of the I6 applications, I don't think I could have gotten in an I6 program with some of the medical students coming through. In my opinion, how to distinguish yourself, if you know from the get-go early on in medical school that you want to do an I6, one of the obvious easy ones is to go to a cardiac surgeon at your medical school, express interest, and try and do a research project with them. I think that's incredibly valuable. That means a lot to me. Mike, what do you think?
Yeah, I totally agree. I don't want to repeat what everyone else said, but of course, board scores and grades are important because that's sort of the first screening. But I think particularly for the I6 program, people, although it's no different than people going into, let's say, urology or neurosurgery, but when the I6 programs first started, everyone was worried, how does a medical student know they want to be a cardiothoracic surgeon, and will they change their mind? And so one of the important things is to distinguish yourself that, you didn't just do, let's say, a sub-I and fall in love with it and then change from whatever orthopedics to now go into cardiac, because people are worried that you'll change your mind in the middle of residency. And so a lot of times people are looking to show that you're committed. And obviously you're a medical student, so you only can do so much. But if you do spend time in a research lab, and and it's bonus if you publish, and everyone knows you're not going to be a first author, as a medical student usually. And so just to get your name on a paper and work in a lab, not just for like a month, but let's say if you worked, for a year or whatever. Or let's say if you can't work in a lab or your institution doesn't have a research lab, show that you're dedicated to the field some other way. Like there's a number of, let's say, members for a day where you could follow surgical mentors through the STS or AATS. That shows some initiative that you're really serious about the field. Or, this is being sponsored by the CVSA through American Heart Association. Another great way to, if you get involved, to meet surgeons from many institutions, to, basically get mentors and, sort of make yourself known, and that it's not just a last minute decision.
Okay, I'm going to address a question in the chat, which is important in this day and age. Someone asked basically, for people who do open and transcatheter procedures, how do we get our wire skills as a trainee, and challenges we faced when you got your job, both OR and cath lab. So I'll start with this. After general surgery and cardiothoracic surgery, I was hired and went and did a vascular fellowship for 4.5 months, roughly, a mini fellowship, where I did not touch an open heart and just did wires. And it was one of the best things I ever did for myself, because it cemented those skills. When I came back, then I started working with the vascular surgeons in a prearranged setup, which we actually modeled after the Penn model, and it's been fantastic. Do I want to do wire skills? Do I want to do wire cases as the majority of my cases? Absolutely not. But it gave me a niche from the get-go, and then I also became a member of the TAVR team. How did I learn that? I was at the back of the table and worked my way up, from gaining groin access to eventually doing the whole case. Those types of arrangements and collaborations are different at every institution, and we'll hear from the panel here, but you have to build that and grow it yourself, and you have to be willing to collaborate for that to really work out well. That's my sense. But I went and obtained formalized training. I'd like to hear Eve's pathway in his training and then in his early career at Pitt.
Yeah, thanks, Brad. I think that's extremely important. And I have 1 day a week. I mean, I operate 4 days a week, 1 day of clinic. Those are my 5 days, and one of those 4 days, at least half of my day is endo, which is a combination of TAVRs, TMVRs, TVARs, and I think it's extremely important. I think it's extremely important to learn. And a lot of times, I tell our residents, because the number of rooms that go uncovered, a lot of the residents are rarely in the hybrid room, and they're in the open rooms because they'd rather not miss, a root or a thoraco, or an arch, but they'd rather miss out on a TAVR or TMVR, which is okay. But I think it's very important to get those skills really honed in early on, because like it or not, that's going to be, now TAVR is the dominant modality of treating aortic stenosis in the country, and it's probably going to stay that way. So it's also important when you're collaborating and working with partners. So again, just like Brad mentioned, I trained at Penn, and so I had those foundations to begin with early on. But when I moved to my job, it was very important for me to be able to do the entire case from beginning to end independently. And when you're able to do that, the cardiologists that you work with, the interventionalists across from you, realize that and respect that. There's a huge difference between a person being able to do any transcatheter case, quote, skin to skin, or sit in the control room and say, oh, it looks good, and it depends on what kind of surgeon you want to be, and I take a lot of pride in being able to do that. Outside of PCI, doing rescue PCI, you ought to be able to manage really any complication that comes from a procedure. Otherwise, it's kind of one of those things, you probably shouldn't do a procedure that you can't manage complications from. But I really would encourage everyone to take advantage of that and do it. And just like Brad said, I would never want that to be the dominant part of my practice, but I also would never give that up. I make a special effort to make sure, it doesn't matter how far booked I am, I make an effort to make sure that I do at least half a day of TAVRs, TVARs, TMVRs. So I keep those skills, and I continue to stay relevant.
AJ, how do the residents get wire skills at Stanford?
Yeah, I think there's the sort of built-in approach to this here, which is, the intern rotation on vascular surgery is crucial for this. But the biggest thing what we do is we have 3 months on the interventional cardiology service as third-year residents. And so at that stage, I think it's nice because you have enough skill to be actually allowed to do these procedures. And so I think I did like 55 diagnostic angiograms. We do tons of TAVRs to the point where I think we're all comfortable doing much of the case by the end of the time. And then we do a lot of work on that same year, the third year, on vascular surgery. And we do a lot of complex EVAR here at Stanford. So we get exposure to really all that stuff here. And so I think that's been crucial. And branching off the theme that collaborating with cardiologists and with vascular surgeons at your institution is crucial. The other point that Dr. Sultan made that I think is huge is that these are the rooms that tend to go uncovered by the fellows or chief residents when there's open cases going on. And so as a junior resident, there's a lot of opportunity to scrub these cases. And I think as in the last several years, for sure, our junior residents have gotten tons of experience doing those cases early on. And I think that's made us all stronger as we go through.
Does any of the other panelists want to weigh in on this topic? Otherwise, we can move on.
I can say one quick, I'm sorry, go ahead.
I do think there's something that is going to be pushed out about structural heart disease, right? I don't know if Dr. Fishbein knows about that, or Jason, you're nodding your head. So I think there might be something that even from like an ACGME standpoint gets moved forward that addresses this kind of broad differential in how people are getting their catheter skills and, other skills in structural heart specifically, because it varies a lot from institution to institution.
Yeah, just to add on to that, I'm obviously not in the room where those discussions are happening, but I did speak to Dr. Tom Nguyen recently, who is very intimately involved in that process. And there are different pathways that deal with structural heart diseases, both HGME and non-HGME tracks, that are coming forward. And it'll be in flux. And I guess what I wanted to add on to that is that as a trainee going into it, or as a student applying to the field, it's very important not to look at this subject and think in any absolute terms. Because I think it's easy to look at something and say, oh, this has happened before, but it'll never happen in this area. Or, this is changing at this rate, but it won't affect me. Like, I think those kinds of statements are very prone for people looking at something because it offers a sense of security. But I think the alternative that's very important to consider is that we have to stay flexible to whatever that can change. I mean, when I was a med student, TAVR was barely being discussed. In fact, I went through all 4 years of med school training without hearing much about TAVRs. And then 3 years into my I6 residency, and I'm still only 30, TAVR has really, really taken off. So that kind of prediction I could not have made in that position. But now I'm reminded of the fact that it's very important to remain flexible, because any of those things can happen in any realm, depending on what kind of breakthrough happens tomorrow. And as a trainee, you have to be comfortable with dealing with the transition within an inherently transitional field. So I think that's a very important mindset going forward for a lot of students looking at this field.
Okay, good. We'll try and zip through these last 3 questions in the last 10 minutes. The next one, I don't think will require too much discussion. The question is, do you think that the stereotype that cardiothoracic surgeons have a poor work-life balance is well-founded or a myth? In my opinion, it's 100% a poor work-life balance. I don't think we should sugarcoat it for you guys. It is a field that can yank you back to the operating room at any second of the day or night. And the commitment that you need to demonstrate for your patients basically puts you on call the vast majority of time. I just think it's the way it is. And if you're looking for a field that has a great work-life balance, I can't recommend cardiothoracic surgery. Mike, what do you think?
Yeah, no, I agree. It's very demanding, but I would say with the reason why we all love our field and so happy about it is that it's so gratifying. It's probably one of the few fields that you still get to diagnose, decide on the treatment option, do a surgery where people immediately are better and have to take care of critically ill patients. You can do it all. And because of that, I think it's worth it. And that's why we all do it. But it is true, it is very demanding. But saying that, Brad has a family, and, many of us have families and kids, and, and that's important to us too. And so you just have to prioritize it. And then I guess the other things, I don't know if, I guess we don't have anybody who's a general thoracic surgeon, but, general thoracic the lifestyle is better. It's still very demanding and technically demanding, but there's not as many emergencies in the middle of the night. Like, occasionally they have a perforated esophagus or things like that. But that, if in the realm of cardiothoracic surgery, is a little bit better.
Jessica, what's your feeling on this topic?
Well, it's like when you're doing something you love, you find a way to make it work. And I think, the career so far has been so rewarding that I feel very grateful. I have 2 kids. My husband is a pediatric urologist, so we're pretty busy. We have a nanny, you figure out how to make things work, but there are ways to make it work. And I think I hope that our kids will appreciate that we both do things that we love and are very rewarding. And I think that makes a really big difference. So yes, you can have balance.
Okay.
I don't know. I know we all argue about even the word balance, whether or not that's even appropriate, but.
Okay, the next question is regarding the current job market, which is very poignant for medical students to hear. How is the current job market for CT surgery in a world with other specials doing similar procedures like interventional cardiology and vascular surgery? I can speak from our universe down at Emory. When I was finishing in 2011, the job market wasn't so hot. In the last 5 years, it's really exploded, certainly in the Southeast. And this gets it to somebody else's question about more clinician community cardiothoracic surgeons as opposed to academics. While we are an academic training program, the vast majority of our residents at Emory go into private practice, and there's nothing wrong with that. And the job market is robust. I mean, we have a guy who landed his job basically with 1 year to go in Florida. It's actually mind-blowing to me. And it seems like our residents have 3 to 4 jobs they're looking at. So in the Southeast, the job market is excellent, and it is not at all limited by the fact that we, do TAVR with interventional cardiology, or we do TVAR with vascular surgery. That's all incorporated into the practices. In fact, you want to be able to go to a training program that gives you those skills to make you marketable for that type of thing, because every cardiac surgery practice is going to want someone who has TAVR skills. Ebes, what's your thought on the job market and where your guys go and pit?
I tell everyone, I think the job market's great because, as you said, a lot of both of our, I'd say all 4 of our chief residents now have multiple leads and interviews and are about to get their offers before they, and separate ones before even close to the end of the calendar year. I think majority of the folks going to private practice or non-academic, and I think that's just the nature of what where some of the jobs are. I think the pay's better, the lifestyle may be better. I think it's hard to turn that down for some folks, so it's hard to blame. But I do think overall the job market, I think, is fantastic. I think with more and more people getting older, I think the chances are that, not chances, I mean, statistically, you need more cardiothoracic surgeons by definition. And I think the more skill set or the broader based skill set you have, the more marketable you will be. That's for sure.
Okay, let's hit our last question in the last 5 minutes. How can you figure out if a program is welcoming and accommodating to minority students, women, African Americans, et cetera, and how do you prepare for that clerkship? My opinion is you need to look at when you go evaluate these programs, you go look at their roster of current residents and talk to them. Usually well, in the COVID era, it's a little different, but pre-COVID, we would have time set aside for the residents and applicants to spend without any faculty in the room so that they could really ask the nitty gritty and feel, unobstructed in their answers. But Jessica, why don't you take a stab at answering that question first?
Yeah, I mean, you want to, most places are going to talk about appreciating diversity, and you just want to see that they're following suit with that, with the people that are, on faculty and in their program, and also the rest of the residency program. You can kind of get a sense of that too, looking at general surgery, what the vibe is in the surgery department, if it's diverse, if there's a lot of women, and stuff like that.
Mike, any other comments on that?
Yeah, no, I agree with Jessica. To look at the residents and the faculty who are on staff, always the best people to talk to are the residents. Also, to look at the institution, is it a priority diversity for the institution? And then sort of another way also to look at it is look at the training program, and it's really important for the training program to show that they're trying to train you in a diverse, hospitals with different socioeconomic backgrounds. Like, do you go to a VA? Do you go to an HMO or to a county hospital where that your training teaches you how to take care of patients from diverse backgrounds also.
Any other questions from the audience before we wrap up in the last 3 minutes? Okay, well, thanks everybody. I thought this went well, very productive. And Jason, tell them how they can get in touch with us via Twitter and all that, since you're our social media mastermind.
So yeah, it's been a pleasure. Thanks for involving us in this programming. I mean, it's really amazing to see 107 participants identifying themselves as an entity that didn't even have a name a year ago. So it's really amazing. So to stay in conversation with us, I think many of you probably already know us in some capacity, and always feel free to reach out. But we have just begun our social media presence over Twitter. It's CVSA_heart. But we will reiterate that at the end of everything. I'm sure the TSMA leadership will send out an email incorporating these types of information, and then hopefully some answers to questions that didn't have a chance to be answered. But thanks for having us.
All right, thank you so much, everyone. Thank you to the American Heart Association and the CVSA. This was a really great hour-long talk for all of us, your perspectives on training, especially personally as a medical student going through my third year and thinking about how I want to do training. This was really helpful for me, and I'm sure it was helpful to our hundreds of other medical students that were joining us on this call. Like Jason said, we will be sending a follow-up email to all of the participants. We are happy to include the contact information for the CVSA as well as their social media presence. And we are recording all of the questions that were submitted but were not answered, and we will email them out to all of the panelists to try to collect some answers and then send them out to all of the participants. Welcome everybody. So I am So excited to begin our last session. For today, we will be doing a day in the life of a CT surgeon. I'm really excited for this because I think this is a really great way to see a variety of perspectives on people that are either currently in training in a variety of pathways or are currently practicing and have trained in a variety of pathways and may be practicing in different capacities. So I think this is really useful to us, especially as medical students, to kind of see what actually is our life going to look like if we pursue cardiothoracic surgery as a career. So for this session, what we'll be doing is I'll be introducing each of the panelists one by one, and they will be giving us kind of a 5-minute rundown of how they trained, what they're doing now, and then what a day in their life is like. And we'll be doing that each one by one, followed by a Q&A session at the end. Feel free to submit questions in the chat. We also have recorded the questions that you already submitted to us on the pre-survey, so we'll probably start with the pre-survey, and then I'll integrate the chat questions as we go along. Again, as we've been doing for the past 2 hours, if there are any questions that we don't get to, we will be recording them and we will send them out to the panelists and send a follow-up email to all of you so that you can get your questions answered. So without further ado, I would like to begin our day in the life session. And if it's okay with you, I would like to start with Dr. Reddy. So Dr. Reddy, he is an attending thoracic surgeon at the University of Michigan. Feel free to take the floor. Tell us what a day in your life is like.
Thank you. So I want to thank everyone for the opportunity to participate and just real quick, I went to med school thinking I was going to be a pediatrician. I thought I was going to do adolescent medicine. That's a long time ago. I ended up doing my surgery rotation, and I was actually bummed out by how much I liked it because I was someone who liked to sleep in until 8 or 9 in the morning. I cannot sleep in past 5:36 now. I ended up doing general surgery. There was no I6 when I trained. I was an intern now more than 20 years ago. And so I did the traditional pathway. I did 5 years of clinical training plus 2 years of bench research. And then I ended up doing a 2-year cardiothoracic fellowship. And then I've been at the University of Michigan as a general thoracic surgeon. So I no longer do heart surgery. I do lung transplants as part of my practice, but I do lung cancer, esophageal cancer resections. I did not do robotic surgery in training, but now have a very robust robotics program. And do about 120 robotic cases a year, and I'm in charge of our robotics program institutionally. I'm also the clerkship director at the University of Michigan for all of surgery. So a day in the life for me, because of my academic and administrative responsibilities, I usually am in the operating room 2 days a week and then have a clinic 1 day a week. That is our setup at our institution. Different surgeons may operate 3 days a week. It's really variable. We're pretty jam-packed in those 2 days that I have. My other days are filled with really meetings, and both research meetings as well as administrative meetings for a number of different roles in terms of the clerkship director, obviously with the med school, and things like that. And so I tend to be very busy, and my day usually starts by 7 o'clock now still. But I happen to live 3 minutes away from the hospital, which is very convenient, which you can't do in a lot of places, but that's important for me and my family in terms of being close by. And so I'm able to be home for dinner about 95% of the time, but that my house is again 5 minutes away. So I don't have to deal with traffic. I don't have to deal with a lot of other stuff. I mentioned, do about 50% of my major cases with a robot. I do another 25% minimally invasively, either laparoscopically or thoracoscopically, and then the remaining cases I do open. So I'll defer the rest of it to questions, but I really enjoy what I do. I would not do anything else, I think, within medicine. And I really enjoy general surgery too, and I thought I was going to do surgical oncology, but cardiothoracic, it's an incredibly rewarding field. You have to like to be busy, I think, more so than a lot of other fields. But I love it.
Great. Thank you so much, Dr. Eddy. And next up, I'd like to introduce Dr. Merit Janor. She is an adult cardiac attending surgeon at Methodist Hospital. I also would just like to give a personal shout out. She was my mentor at the STS through the Looking to the Future Scholarship. We've talked a lot about, they've referenced a lot of these scholarships. If you sign up for our TSMA listserv, we will be emailing everyone updates when these scholarships are happening, when you can apply for them. I just wanted to let everyone know these are really great opportunities. That's actually how the TSMA got started. But now, Dr. Merritt, you have the floor.
Well, thank you and congratulations to you guys. What a great start to the session. So really proud of what you guys have been able to do so far. So as Eleanor said, I'm an adult cardiothoracic surgeon now. So I previously was in academics for about 5 years. I was the program director of our traditional fellowship at the University of Nebraska Medical Center. And I have transitioned into private practice. So it's been an interesting 2020, I think, for all of us. And added to that is a little bit of a career change. So I wasn't doing cardiac surgery for I was just doing cardiac surgery for 5 years, and now I'm doing cardiac and thoracic again. So I might have to hit up Dr. Reddy for some tips and brush off a little bit of the dust. I did an I6 pathway, a little bit different. I started off as a traditional resident. Again, there were only traditional pathways when I started. And then my program started one of the first I6 programs at San Antonio, and I ended up taking that spot my second intern year. So I did an I7 pathway, but I really liked that training. I always knew that I wanted to do cardiothoracic. That was always my plan coming out of middle school, high school, college, med school, so all the way through. So that ended up being a really nice pathway for me. A traditional day for me actually looks a little bit different now. It used to look really similar to what Dr. Reddy described. You know, a lot of administrative meetings and planning and academic sessions and, you know, coordinating the education for the residents in addition to juggling the careers that we all have from a clinical standpoint. Some straightforward cases and some less straightforward cases being at a major academic center. So now it's a little bit different. There's a little bit more, I'd say, flexibility in private practice where you are a little bit more in control of when you want to start a case and the cases that you need to do. So that's been a little bit of a welcome change for me from a personal perspective. I'm sure some of you saw I've got a little girl here. I've also got a little boy. So juggling that time commitment was really important to me at this stage of the game. So as much as I loved the academic side and teaching, I knew that I needed to rebalance at this stage in my life. So I'm happy to field any questions about that as well.
Great, thank you so much, Dr. Merritt. Our next panelist is Dr. Jason Hahn. He is an I6 resident at the University of Pennsylvania. So Dr. Hahn, tell us about a day in your life.
Yeah, so currently I'm on my research time, which is really the most amount of time and flexibility I've had in the last 3 or 4 years. And I'm thoroughly enjoying that aspect of it, although there's some aspects that are chaotic about having too much freedom, I would say. But to speak about my clinical experiences, I think as a resident, you're expecting for your day to begin at a very early hour. You're probably waking up around 5 or 5:30 every morning, depending on if there's commute involved. It may be even earlier than that. And as a resident, you really are answering to the clinical demands of the hospital, the service that you're in. So if that means that you have to stay late to do a late start case and your night ends up going until 9 p.m. or 10 p.m. or 11 or beyond, then that is the nature of your job. So I would say that when you're planning different aspects of your life, such as when to conduct research, when to speak to someone who's interested in the field, when to speak to your own mentor, and et cetera, you're not necessarily planning on a day-to-day basis. Oftentimes I find myself planning my life in a sort of week to week or like a rotation basis. Oh, it's going to be really hectic for the next 14 days, but then I'll have that weekend off during which I can catch up on some things. Or these 3 months are going to be very hectic, but in April, I'll have some time to gain control over some of my schedules again. And I think that's just a natural transition that you will end up, that all residents end up undergoing as you begin to sign up for this rigorous training path. And it doesn't necessarily mean that you're losing control over something. In fact, some of the most rewarding periods of my life are when you're losing yourself in that kind of hectic schedule. You're running a marathon, and at some point you lose track of how much you've run, but you're just going forward. And by the time you reach that finish line, it's incredibly rewarding. So from a residency schedules perspective, it's never going to feel like you're quite in control of every moment of it. And you may be planning in longer blocks of time than you're used to, but overall, that's the nature of the job. And I think it's very rewarding for that reason.
Thank you so much. Our next panelist that we have is Dr. Christina Constantino. She is a thoracic fellow at Massachusetts General Hospital in Boston. Dr. Constantino, you have the floor.
Do you mind if I share my screen?
Absolutely,
quickly?
I would love that.
All right. I put together a quick slide. So everyone. First of all, thank you for having me. Congratulations on this group. This is awesome. Great resource for everyone. I'm Christina. I am a P4 resident, MS General. I applied to a traditional general surgery program. I knew I was interested in thoracic at the time I was applying, but I studied general surgery and wasn't ready really to commit to any at that point. I did my first years with exposure to cardiac and thoracic during my surgery time, and my research years applied to our 3 cardiothoracic fellowship, to which I started this. So I'm in my 4th general surgery year, and then also am actually currently right now actually in one of my fellowship blocks, where we get to do basically 6 months of CT integrated into our surgery clinical time, and 2-year on top of that's pure cardiothoracic, all at Mass General, with a couple of weight rotations as well to different complexion of institutions. And so just in brief, day in my life, I would say starts about 5 o'clock or so, very close to the hospital, and that was purposeful. I couldn't get about 3 minutes walk. I usually review our patients for the day. I review our operations, whatever case I'm assigned to for the day. I like to do this in the morning because I feel fresher. And then if there's any reason in the morning, you get a little more time to actually know about things before you start at rounds. A thoracic resident, you'll be with chest x-rays. So usually we begin rounds by 6, and by 7, I've seen everybody and staffed with whatever attendings. I'm responsible for their patients and basically get to go to the operating room. The rest of the day is pretty much spent in the OR, as, senior resident doing a variety of cases. They can be, I love about thoracic, you can have a day that are all bronchs and needs and some shorter cases, and you can be also doing, longer esophagectomy or, more complex, lobectomy. So it offers a really nice complexity of operations, and I've found it to be both very long days, but also very stimulating, very full, and I'm happy with choosing specialty. All of us have intermittent Zoom meetings of our days now. That can be from our didactic education center sessions to sort of afternoon conference that we still have for residency and fellowship education time, and also check-ins with our director and things like that. I also tend to, depending on what time we get out of the OR, spend that time catching up on my patients that I haven't done in between, or if I haven't had the opportunity to see people. And we'll also try and do things like making a dentist or something for like my any of that sort of stuff. Lesson in multitasking and triage life, but it's busy, but a full day, and I try my very best to get out of the hospital if I can. Many days that's not possible. It depends if you're in the operating room, if you have clinical responsibilities or patients that need you helping to manage. But once and as I said, I typically try and get out of here by 6. I live close to the hospital, so if I need to come back, it's very simple for me to do that. I have an amazing partner who helps us juggle this life and our 2 kids. It's an interesting, sometimes, as I think I've said before, messy but it's all worth it and awesome. And I put this picture of me sitting in a cardboard box here because you can just spend the day learning about pulmonary artery and how to get around it, and I come home at night and you're cardboard box with your kids, but it's been an awesome integration of my life. So after they go to bed, typically spend the evening trying, if I am able to stay, I will spend the evening trying to do a couple things I need for the next day. Sometimes that includes my operative cases the next day, or other academic stuff that we need done. I put up for, this was a tracheal simulation that we had done on a weekend, a Saturday morning. That was one of our education sessions, and it was just an hour or 2, and it happened to be a weekend I had off. But being, it's a fun opportunity to learn with your residents, PIG lab that, and so training is it's a hard time, busy, it's full, you don't always have over your entire schedule. I have really loved the path I've chose. It's a great specialty. I couldn't echo enough choosing a program that you're surrounded by people that you really enjoy. And I know that's hard to sometimes always outset, but I'm really fortunate to love where I'm training, and you know, I'm happy to fill any questions as well. So thank you. Stop sharing my screen. So
Thank you so much, Dr. Constantino. Our next panelist is Dr. Tony Moser. He is a thoracic fellow at Northwestern University. Dr. Moser, feel free to tell us what a day in your life is like.
Hey, everybody. Tony Moser. I'm the chief fellow at Northwestern. I did not know what I wanted to do in med school or anywhere before or anywhere after. So I've tried all of it. I am a traditional fellow. I did 6 years of general surgery, and I went to business school during my research time. And then I'm 6 months from finishing a 3-year traditional fellowship. So I'm a PGY 9, not that anyone's counting. It's a long path, but it's a great path, and you learn stuff every step of the way. And, you know, I think it's important to mention to those of you that are 1s and 2s that you don't have to know that you're going to be a cardiac surgeon when you start doing this stuff. And there's plenty of opportunity to find your way and find yourself and find the mentors and sponsors that help you get through each and every step all along the way. I thought for a while I wanted to do vascular surgery or trauma surgery, but CT surgery is the best. There's no question about it. I recently made the decision to go more towards cardiac surgery than thoracic surgery, and so I'm actually in the process of interviewing for jobs in that area, and happy to talk with people about the job market offline if that's of interest to you, although it'll probably be extremely different by the time you guys are at that position. A typical day for me, I am in charge of our block schedules and managing the manpower grid and so forth for all of our teams, both cardiac and thoracic. And so I deal with those issues as well as any offline issue regarding the way the service runs, what complaints the students have, what roles people are taking the OR, that kind of stuff that the chief person does. But I also am currently on thoracic surgery. And so yesterday I did an esophagectomy with one of my junior fellows, and today we did a robotic Nissen, and we had a double lung transplant and a right upper lobe robotic resection for a recurrent metastasis in a young woman. So just because you choose cardiac doesn't mean you don't love doing a great minimally invasive esophagectomy or a great robotic Nissen. And that's what's the beauty of this specialty, is that all of the operations are awesome, all of them. We love to have fun in the operating room, and there's, I heard some commentary in the previous group about, you know, hey, what do you think about CT surgery when there's other specialists doing similar procedures? Nobody's doing similar procedures. Nobody can put somebody on ECMO. Nobody can put somebody on bypass and operate on their heart. This is a really special specialty. It's a small group. It's a tight-knit group. People know each other. People respect each other. And it's really, really great organizationally, and a really cool group of people to be friends with in and out of the operating room. And it's a really, you know, I don't have anything bad to say about this specialty choice whatsoever. Let's see, I think that about covers it for me. I'm happy to also, as everybody has voiced, happy to answer any questions. And you know, I'm excited for you all to be doing this at this stage in your life. This is what works well when you start identifying what you think is what you're looking for, and you start reaching out to people like Dr. Reddy or Dr. Merritt, who might offer you some mentorship and sponsorship opportunities. That's a great move. So you've already made a good first move here. Thanks.
Great. Thank you so much, Dr. Moser. I don't believe our last panelist was supposed to be Dr. Leah Backus. She's a thoracic surgeon at Stanford. She did notify us that she did have a late OR case today, so she may be late or may not make it at all, but regardless, if you do have any questions specifically for her, feel free to send them in the chat and we will email them to her if you were particularly looking for her on the panel. But thank you so much for sharing what a day in your life is like. Now I think we have time to transition to the Q&A portion. So we have some questions that you guys already submitted, but you are more than welcome to submit questions in the chat as well. I see that Dr. Reddy has already done a very proactive job of answering some of the questions, which is awesome. Thank you so much for doing that. To the other panelists, feel free to chime in as well. But some of the questions I'd like to pose to you all, we've touched on this a little bit earlier today, but I think this is a really great group of panelists to specifically ask this question, which is the question that is asked at almost every webinar about CT surgery for med students, and that's talking about the work-life balance and wellness, lifestyle, and family. I would really love to have a perspective from each of you, since it seems like all of you are at different points in your training, and all have already shown us that many of you have family lives at home. So I would really love for perspectives from each of you if you would like to share anything on your perspective working in cardiothoracic surgery while balancing your life outside of CT surgery.
I can just start briefly. I have a 4-year-old and a 9-year-old, but I've been in practice now 11 years. And so I waited. My wife is not in medicine, and we chose to wait until after I was done in training. It sounds like there are a lot of people here on the call who have kids, and kudos to you. I think it is so hard. It's so hard to be a parent, period. It's hard being attending and a parent. And to be a resident, a parent, or a fellow and a parent, I think is even harder. So, so I don't know how to do that because we chose not to do that. And so, but having said that, it's when you're an attending, you have a little bit more control, as Dr. Merritt was talking about. In terms of the type of job you choose and the type of where you choose to live, and all of those kinds of things are huge factors in terms of your family. And so when I have students who are going into surgery or CT surgery, I think it's important to think about what your family plan is, what your next 5, 10, 15 years are. And you also have to recognize that what your choices are today may be different in 5 years, and that's okay. And that programs are so much more flexible now than they were 20 years ago, in my opinion. There's still room to go. They're not, amazing by any means, but we're making progress in the right direction, in my opinion.
I'll chime in if that's all right. Just to incorporate what Dr. Reddy said, and also a little bit of what Jason said when he was speaking earlier. I have a 3-year-old, and my wife is in medicine. She's an internist. And so when I'm on the cardiac service, FaceTime time is 7:15 before I start my case. And when I'm on the thoracic service, FaceTime time is 6:45 before I start rounds. So making time is all about planning ahead, like Jason said, and building a family along with building a career is doable as long as you build blocks of time the way that you can. And you have to plan for contingencies, but we're pretty regular about our FaceTime time, and we usually do those faces like the animal faces, so he doesn't forget who I am because I'm usually the dyno. So those are the things you do in this career, and it works fine.
Yeah, I'll chime in. I mean, I couldn't agree with Tony more. It really is about putting in the effort to plan and knowing that sometimes you may be disappointed because a plan doesn't work out. And I mean that because some of the schedules that you'll be participating in will be unpredictable in nature. Maybe you planned a nice dinner for someone's birthday, and then that evening you end up having a complication that keeps you in the OR for another 2 hours. There's no one to blame, but that's the nature of the work. I don't think that anyone should give up on planning or lower their expectations as a result of it. That would be giving up on the perspective of having a work-life balance that I think the field is beginning to more widely recognize. But just be open to the idea that you may be disappointed from time to time, but through efforts like what Tony's saying about keeping in touch with his children, one of my chief residents uses FaceTime and walks around the hallways of the ICU with his AirPods on, talking to his kids every single evening and every morning. And those are the efforts that you have to put in to make everything somehow, tenuously but sort of delicately and meaningfully hold together. And it's going to be a continuous process throughout the rest of your career planning, and you just have to be okay with that.
Yeah, I totally echo what everyone else has said. I think that there is a good deal of self-sacrifice, especially during training. I had my first in training, I was a PGY3, and I know there were a lot of times that you just come home completely exhausted and you want to go to sleep, and instead you're in a cardboard box, playing with your kids and just really just embracing that time that you do have. So I think it's about not necessarily the quantity of time that you have, especially when the time is crunched, but the quality of that and building those relationships. It's about relying on your partner to be flexible, to have family support. My parents actually moved up to Omaha about a year and a half ago when I had my last daughter. And they're key to helping maintain a backup plan, like you said, a contingency plan. My husband's out of town next week. My parents are going to help me get the kids to school and whatnot, and cover, if there's a dissection or something. I think the other thing that you'll find is that, contrary to what people outside of our specialty seem to believe, there are a lot of people who really value their family time and really prioritize that family time. I think a lot of the meetings, you'll see that many people bring their kids to those meetings, like STSA. I'm really missing it this year. That's where I go with my family every year. We have like 3 other CT surgery families. We meet at the pool, have beverages and, hamburgers, and watch the kids get bigger. And our kids are all friends. So I think you'll find that there is just an amazing fellowship of CT surgeons as well. Like Tony said, it's a really small group and we're really tight knit and we care about each other.
I think the only thing I would have to add to some of the stuff that everyone has said was that, being, I haven't seen what the other, I still have 4 more years of training. So I look things back to what it was like during my 1 through 3 year when we didn't have, and I almost think my husband's an hospitalist. I think to myself, like, we were like ships passing and actually see or do things that I thought we didn't even have kids at that time. And so I think that thing that you love, or interested in, do, or want to dedicate to, requires effort, and to sort of carve it out, and also to make sure structure your day. I would say that I actually do a better job of that now as a senior resident with kids. Literally the day is packed and it's intentional, and in every it makes it a little more exhausting, but every minute in the hospital that is free is something that may accelerate me able to like clean things at the end of the day. So it's just like it's a triaging and multitasking. I do think it's part of our specialty regardless, but you have to be a little bit better at it when you integrate some of those other pieces of your life. And it's not going to be perfect. It's never perfect. I've missed plenty of things. I've come home late plenty of times. Working on trying to figure out balance. We don't have family nearby, so we've a lot of people locally, and my husband in particular, and you sort of have to figure out ways to sort of make that all work. But it makes for a very full life. I've really, there's only been a few days where I'm like, this is a little too busy, but most of the time you love your work and you love your family, or whatever your things of at home are. And I think it's possible, because the reason why I felt this way early on was I met mentors who had the same experience and sort of figured out a way to juggle what was important in their life, whether that be a family and kids, whatever their personal hobbies were, etc. And so I would encourage you. It was something that was worried about. I encourage you. You just have to sort of get in it and get through it. And it's probably changed the stage of your career, but certainly all worthwhile.
Great, thank you so much. Those were all really, really interesting responses to hear, especially since you guys are all in different aspects of your training and are practicing in different areas. It was really nice to know that you all find a way to make it work. and that you can make it work. And I think that's really important for us to know, especially as medical students, considering a lot of times we may only know you in the capacity as a cardiac surgeon, and we don't really know what goes on outside of that. I think it's important for us to keep that in mind, that it is possible to have both. Another question that was brought up in the chat, which has yet to be answered, and I think this might be interesting to hear, especially for medical students. It's talking about what practice is like in different centers. So whether it's an academic center, an academic affiliated center, or private practice, what is CT surgery like? I think as medical students, we're really mostly exposed to academic centers. So that's kind of all we get to see. So if any and all of you could comment, and especially Dr. Merritt, since you brought up that she's now working in private practice, kind of what are the differences between that, and what does it actually look like once you're practicing in those settings?
Yeah, so I think you're totally right. The only exposure any of us have during our training is academic centers. So, during medical school and residency and fellowship, obviously you're training somewhere that trains other residents. And so it's hard to know what it's like on the other side, if you will. I was originally pretty reluctant to take a job in private practice because I had this perception that if I leave, I can never come back. I guess I don't know if that's true or not yet, but I'd like to think that I put forward 5 good years there, and we'll see how things end up. It's different. I tell people, people always ask me, well, what's it like over there? I'm literally across the street from my old hospital. So that's a little bit interesting as well. And I say it's a different kind of hustle, because it's true. You're used to having an army of fellows, residents, nurse practitioners, critical care staff. And that's just not the case in private. You're kind of I do have a nurse practitioner and I do have a PA now, but it's different. The expectations are different and the roles are different. And so a lot of the things that I probably got used to someone else kind of making happen behind the scenes are now my job again. I've got to think about all the orders and call the consultants and really just make sure that people are moving through, and especially on the weekends. It's just me. I'm rounding on 20 patients, So it is different. I'd say the case volumes, it's more variety than probably I saw, doing both cardiac and thoracic. It's a really unique challenge for someone to go from, becoming an expert at what they do to now becoming a novice again at doing thoracic. I wouldn't recommend taking 5 years off and then jumping back into it. It's a little bit of a jumping in cold water. But that being said, it's a challenge, and it's kept me from getting like super comfortable or complacent in what I'm doing. I really enjoy seeing the different cases and being involved in tumor board and, all of those different things. The case volume is about the same. I'm probably doing more cases than I was doing in academic, but the efficiency is just really different. You can do 3 cardiac cases in a day and be done by 6, and that's a regular day for you. Whereas in academics, the turnover takes longer because there's trainees at every stage of the game. And that's not a bad thing. It's just the nature of academics versus private. I would say the job market is really, really good for anyone going into cardiac thoracic or cardiothoracic. Probably you guys graduating shortly can speak to that, but I mean, there are a bunch of jobs, and really the world is your oyster in choosing the one that fits perfectly for you. So.
Thank you so much, Dr. Merritt. Do any of the other panelists have anything to add?
I've been in academics my whole career, so I have no idea. I've personally asked our fellows who've gone into private practice not to tell me how much they're going to make, and not to tell my wife how much they're going to make, because I don't want to know. The clinical work will be similar. There's going to be some nuances in terms of scheduling and stuff like that, controllability of lifestyle, and definitely there'll be differences. But I think it's a little bit about what you want to do and what your practice what kind of practice you want to have. So, as Dr. Merritt, has had the exposure in terms of, working with residents, working with students and things like that, that is part that I think we all value. But at some point also, you have to make decisions about, everything about where you want to live, what kind of job you want to have, and, most importantly, I think how you want to support your family. So.
I'm facing that discussion and decision making right now. There are major positives to the academic setting that are difficult to replicate in private practice, specifically teaching, mentoring, and training. And as Dr. Merritt alluded to, you have an army, and all of us trained in that army, and then you finally get to be the person like sort of the head of the army or leading the army and benefiting the most, and then you say, oh, I'm just going to go into private practice. So I haven't answered that question for myself. I'm dealing with it right now when I'm going through the interview process for jobs. But there are definite upsides to either, and I think there's good work to be done in both.
Great, thank you for those perspectives. So a question that was pre-submitted to us that I'd like to pose to all the panelists, and feel free, whoever would like to answer can. So one of the things that we've learned about over the past 2 hours of this webinar has been that one of the things you can do as a medical student to get involved in CT surgery this early is to get involved in research. And so one of the questions that was posed to us is, what's the best way to get involved in CT surgery research if you aren't having a lot of luck at your own institution, if your own institution's cardiothoracic surgery department isn't very research oriented?
Yeah, I can start us off on this question because I'm on my research time. In general, I would answer that question even more broadly. Like, reaching out to people for starting research is important, but in that vein, you're also going to discover a whole lot more, because that typically involves you looking into opportunities that you wouldn't have otherwise, such as going to conferences and getting to meet residents at a program that'll also open doors for you. So just from attending this webinar, I mean, you guys have made a decision to spend your Thursday evening for 3 hours listening to topics in CT surgery training. And I'm sure you've taken away a lot of terms that you can go look up in the future. All these kinds of things will add on. Specifically about planning research, I personally think that if there is a CT surgery interest group of some sort at your institution, starting there is a very good point. Even if there isn't, starting something like that and connecting with a national organization that exists, whether that be the TSMA or the TSRA, is a good move that you can participate in. And that way you can get connected to institutions that may have a more established academic precedence in terms of guiding you in that direction. But in general, I think reaching out to senior medical students or residents who are working closely with attendings and can give you the layout of the landscape is very important, because they'll give you honest opinions about what they can offer you, what skill sets they're looking for in you to develop, and which attendings are good at producing which types of work. And all of these things really matter in terms of joining those interests together, because that's the way that you're going to find the most amount of productivity. So I think finding someone that you can have that frank conversation with is very important.
I'll ask, just for my own experience, my first couple years of residency, the stuff that I did involved in research were very short, papers or writing chapters or something for our faculty. It was a nice way to get involved, both like forming a relationship with faculty, learning a little bit about CT surgery, and it's not as like labor intensive in terms of doing a clinical study or something like that. We're very busy as a clinical resident. I think it also opened some doors for me to start looking at what I wanted to do during my research. That somebody wrote in the chat, just to be specific about what my research years were. Academic, or most academic programs have at least 2 dedicated years where you will, and for general surgery specifically, you'll do 2 years of research in your 3rd and 4th year, or your 3rd year. And so we have a 3rd and 4th year. So that opened up the door for me to do some thoracic oncology research. If you have surgeons, for example, who are maybe academic in some of the research areas, one idea that I ended up working in an oncology lab in thoracic oncology. Wasn't what I had set out to do, but these multidisciplinary boards are, they're all fine. So if you're interested in doing surgical, you may still be able to get involved in some research that, you can link your department into something that is some clinical application for surgeons as well, intellectually stimulating. And you also about, both just basically oncology and things like that, just like another suggestion as another something that you might not have if you don't have an institution. that's just something that I do in my research time. So.
Great, thank you. So another question that was submitted to us ahead of time, this is kind of a broad question, but a lot of medical students, they realize, oh, I really like CT surgery. I think this is something I want to pursue. How do I kind of start building up myself to be the best candidate to then apply to residency in whichever program you decide you want to, or pathway you decide is the best way for you to train? What are some things, we've mentioned research before, but what are things outside of research that you can do as a medical student, not necessarily just to make yourself better on paper, but actually to develop your own skills personally as a medical student so that you're prepared for your training?
So, I mean, I'll talk a little bit about, you know, the key. So for one, you got to be a good doctor. Okay. So, you know, occasionally we have people who are really very focused on surgery or cardiothoracic surgery, but who kind of don't pay attention to the rest of their med school classes and things like that. So we all need you to be good doctors. So really focusing on all of your med school curriculum, psychiatry, neurology, all those rotations that, you know, you may not be as interested in, but still you got to do a good job and learn how those things work. The other major thing that everyone needs to do is, I think, find mentors. Someone asked me in the chat, I don't remember if I responded all, but you know, the STS at least, and I'm sure the ATS is also, you know, is committed to helping students and residents find mentors in cardiothoracic surgeons, because we recognize that not everyone's in an academic program with a cardiothoracic academic faculty. And so if you contact those two organizations, both are committed to finding you people within their membership, but the STS, basically almost every cardiothoracic surgeon is a member of the STS, and the ATS is more focused on academic faculty, but they will find you faculty who at least are local to you or regional to you, who you can potentially contact and meet with. Right now, COVID, you know, is obviously, you know, changing a lot of that in terms of visitations and being able to go to other hospitals. But in non-COVID times, you know, there are a lot of opportunities like that.
Great, thank you, Dr. Reddy. Do any of the other panelists have anything to add?
I think I can add a little bit. Sorry, go ahead, Dr. Merritt.
No, you go right ahead.
Yeah, I was going to say, you know, as a current M4 is going through the whole process and is busy applying it, you know, it is tricky, especially coming from smaller institutions that aren't large academic centers. But, you know, as it's been shown many times tonight, mentorship is so key in getting you tuned in, whether it's for research or other opportunities. And a lot of these different resources like STS, ATS, even this own organization, at giving you the information to help you make decisions and start making the connections that you need. And as far as once you get into the clinical space, or even before, if you can get any clinical exposure and start to really understand the basis of the medicine, it's going to be a lot easier to try to figure out a way to justify why you actually enjoy that specialty and what makes that so special for you once you're actually in a clinical space, which can be a little bit hard, especially now during COVID, as Dr. Reddy was saying. But it's definitely really important later on as you try to explain why you want that specialty too, which is always a question that comes up.
So I'm probably a little bit of a non-traditional cardiac surgeon in that I'm a female and I'm a DO. And so I think I take a different approach to maybe looking at the applications than others at other institutions may take. I actually completely blind myself to any of the scores. I look at the person's personal statement, their extracurricular activities, leadership activities, charity activities, and their letters of recommendation. And that's kind of painful to look at those things first, but I think that I'm looking for somebody who stands out, for somebody who has grit and can make it through the training process. I don't think that scores make you a good doctor or a bad doctor. And then if I have to weed it down from there, obviously all of us have to have applicants who can pass their boards, or we can't stay open as training programs. That is the end goal for every person coming through training. You have to pass your boards to be a practicing surgeon. So, you know, I look at those things obviously, and I'm looking for a certain amount of, you know, ability to take a standardized test, but I'm also looking to train good doctors. You know, as the other panelists have referred to, we want people who are good doctors first, good surgeons second, good CT surgeons third, maybe good people first. Go with that.
I totally agree. I think that aspect is often underappreciated from the perspective of applicants because you're worried about all these things that you have to objectively put together in your application. Having been on both sides of that process, in the beginning, I worried about the same things, but now that we look at applications, I've never seen a score. Sometimes it's used to get your foot in the door, but that's just sort of like a minimum that a lot of programs consider. But I've never seen a score or some other superlative objective characteristic determine someone's candidacy for a program. Like I've never had I've never heard our program director or our chairman say, because this person had the highest number of publications or the highest, step 1 score, we're going to take this person. That maybe it's a culture that's changing in some ways, but more of them are asking the residents, whether this student was a good team player while they're on rotation. I can only speak about an I-6 program, but they're choosing to take on someone. They're choosing to train somebody for 6 to 8 years. And that is a significant chunk of time that they're investing in somebody. And they really want to make sure that that experience is with somebody that they can rely on, someone who cares about patients and about other people, someone who's willing to work very hard and not cut corners. And as my program director likes to say, the number one thing that I consider in applicants is whether you can take feedback and then improve yourself based on that. It sounds very obvious, but it's not something that you can take for granted in anything, right? I mean, so when you're looking at somebody applying to the field, sure, those objective characteristics are important, but what really makes someone shine, I think, is these sort of grayer areas that you bring to it as a person. And I couldn't emphasize that more. I agree with Dr. Merritt wholeheartedly.
I'll just tell you from the other side, having been in charge of grading for a long time now, historically, programs did look at step 1 scores and at publications. I think everybody is trying to take a much more holistic view because we've recognized over the last 10 plus years that exactly what's just been shared, that your step 1 score does not make you a good doctor. And step 1 scores are going to be pass-fail in a year and a half, I think. And so, I will just tell you, all residency programs, not even in CT surgery, everybody's freaking out because we are trying to figure out, how do you judge applicants now? And that's the whole other discussion. But having said that, there is a shift towards more holistic evaluation of applications, which is a good thing.
Great. Thank you so much for those perspectives. I think that's really important, especially over the course of the night. We've had a number of likely first year and second year medical students asking questions on how the shift to pass-fail of step 1 is going to affect them applying to programs, especially competitive programs like I-6. So that was really good to hear, I think, that to emphasize the holistic approach that programs are now taking to evaluating applicants. So the last question that I'd like to pose to each one of our panelists before we wrap up tonight would be, what do you wish you knew about the field of cardiothoracic surgery before you started? This might be a little bit of a thinker, but I'd really love input from each one of you. I think it's especially since we have yet to enter the field, it might be interesting to know, what do you wish you had known before you started going in? And if it's okay, I'd like to go down the panel just like we started. So if we can start with Dr. Reddy. Oh, Dr. Reddy, could you unmute yourself? Thank you.
Sorry, I was responding to the chat. Sorry, what was the question again?
Oh, no, not a problem at all. So the question is, what do you wish that you had known about the field of CT surgery before you went into it?
I don't know. I mean, I came the long circuitous route. So I think I came in eyes wide open. I did research in thoracic oncology. I had a number of mentors. I mean, I think the key is, again, as I mentioned earlier, is that you have to have more than one mentor also. You have to have multiple mentors in the field who know you and who you get to know and you get a chance to observe with, especially early in your career, to, kind of eliminate some of those things. I guess the biggest surprise, and this is, as you become faculty, the level of responsibility can sometimes be overwhelming. I guess that's the one thing, and I mean, I'm 11 years in now, so I mean, but that was probably the biggest lesson in my first 3 years of practice, and Dr. Merritt can probably attest to the same thing. It's the buck really does stop with you. There is nobody else to call at some points in time, and you get very good at operating in a field of blood, which is a very unique skill set. unfortunately or fortunately, I don't know. And so that is a different level of stress than I guess I maybe ever really appreciated. You do learn how to get through that, but I think it's a challenge for all of us to learn that, especially early in your career when you're done with training.
Great, thank you, Dr. Reddy. Dr. Merritt, do you have anything?
Yeah, you took the words right out of my mouth. That's exactly the theme that I was going to say, is that when you're a fellow and, you know, stuff hits the fan, you know that your attending can get you through that. And when you're that attending, you have to dig deep, and it hits you differently when bad things happen, because you know that sometimes it's not a direct reflection of your skills or abilities or what you did in that moment or not. But when it is, and you think that you could have done something better, man, that really stays with you, and it haunts you. You know, there are cases that I still think about to this day. I think about the minute it happened, or, you know, but then on the flip side of that is this just amazing relationships that you form with your patients that you think you were forming as fellows, but it turns out it's even better when you're the faculty. Like there's just this bond that can't be broken between, you know, a CT surgeon and their patients. Like, they make you quilts and they bring you coffees. They notice what you're drinking in the morning. They make you cookie. It's like, it's amazing. And I'm not talking about the gifts. It's just like that gratitude and that kinship that you share. I just think that that's really unique to our field, and it's really great.
Great, thank you so much, Dr. Merritt. So I just saw that Dr. Backus was able to join us directly from the OR. I would love if Dr. Backus, we could backtrack to the first question we had today, which is, what is a day in the life, a day in your life like? Dr. Backus, if you would like to walk us through, one of the things we also asked the panelists to share was how they trained and where they are currently practicing, in what setting, and then describe a day in their life. But you are more than welcome to take the floor. Welcome to the meeting.
Thank you so much. My apologies for not making it. This is part of the day in the life, missing meetings or showing up late to meetings, because there's only so much we have control over in the OR, like other people's cases. But I don't want to backtrack too much since I know it's getting late and whatnot. The questions were like our training, is that what you said? Like our training pathway? And
yep, how you trained, and then what a day in your life is like now that you're practicing.
So I did my general surgery at USC, and then CT surgery at UCLA, and then Dr. Reddy and I switched places, and I went up to University of Washington, if you will, to have my first faculty job there. Which is fantastic. I was there for 6 years, and then I came, was recruited back down to California, and I've been at Stanford for 5 years. So Dr. Reddy and I are the same year. I split my practice, half here at Stanford and half over at the VA in Palo Alto, which is fantastic. I really like that mix. I was when I was in Seattle, I was almost all VA with the exception of like lung transplant. And I was very happy to give up lung transplant and to come back to Stanford and to have a mix of both. And so I really like having both practices, if you will. It's kind of adds up to a little bit more than 1.0 FTE though, because even though they're only 2 miles apart, you still have to maintain kind of relationships and patient panels and that sort of thing in duplicate. So, but they're very complementary, I think, honestly, the patient population and what I do. So I operate a day a week here and a day a week there, and same thing with clinic, and then a bunch of research and admin in between. I have 2 big grants that I administer to. One's on the VA side, one's on the Stanford side. And so days are pretty full between all of those different things. So every day is different, honestly, because even if it's two days that are both OR, one's here at Stanford and one's over at the VA, and that's kind of a difference in and of itself. But it's fantastic, and I certainly wouldn't have chosen anything other than what I'm doing right now.
Great, thank you so much, Dr. Backus. And with that, we are actually out of time. It is now 10 o'clock. I want to thank all of our panelists here. I'd also like to thank all of the participants for sticking around for a full 3 hours today. To the panelists, thank you for sharing your insights, what a day in the life is like for you. This meeting was recorded, so hopefully the participants that weren't able to stay on the whole time or weren't able to join live will be able to view it in future. But yes, thank you so much for joining. Just a few announcements for the participants. I will be sharing my screen so that you can view a QR code, which has a post survey. We would love for you to fill this out. We will also be sending you a follow-up email with this post survey, as well as a link in order to sign up for the TSMA email listserv, where we'll be sending updates, newsletters, and a lot of the scholarships that we've been talking about and mentorship opportunities. Those we will be sharing on the TSMA email listserv as well if you want to stay up to date with those. So with that, I would like to say good night to everyone. And again, thank you so much to all of our panelists. It was really great to have you and to be able to learn a little bit about what a day in your life is like and why cardiothoracic surgery is the best.